Good evening, everyone. Myself, Dr. Poonam Shah from Integra's Healthcare, and I would like to welcome all of you for this session today on Optimizing Pregnancy Care series by ISOPART Mumbai chapter, an educational grant by Integra's Gynecology Department. Before we move on to today's session, I would just like to give you a small brief about Integra's Health. Founded in the year 2018, Integrace is the youngest among the top 85 pharma companies in India, and we have been ranked as 13th in the gynecology represented market, trusted by more than 42,000 Indian doctors, and among which more than 5,000 are the gynecologists. We are the leaders in two therapy areas in the gynecology space segment, the ANC care, where we have the progesterone and the hematinics, and the vulvovaginal infection management. With this, to take today's session ahead, I would like to introduce Dr. Komal Chavan, the convener of our series. Dr. Komal has done her MD, DNB, MNAMS, FCPS, TGO, and FICOG. She has also done diploma in reproductive medicine from Germany. She is a medical director at Chavan Maternity and Nursing Home. She is an honorary professor at Dr. R.N. Cooper Hospital and HBT Medical College. She is a chairperson, POXI Medical Disorders and Pregnancy Committee. She is also a member, Managing Council for MOGS, a member of the Managing Committee AFG, and a joint secretary to ISOPAP Mumbai chapter. She is an editor to Psychological Issues in Obstetric and Gynecology. She is an editor, Monogram on Hematological Disorders in Pregnancy. Along with this, she has also received numerous prizes, to list a few like Foxy Championship Award, Wonder Foxy Award, uh, then a Smart Conference, and the UXI Youth Mela Appreciation Award. With this, I would like to invite and welcome Dr. Komal Chavan, and I would hand over it to you. Over to you, ma'am.
Thank you. Thank you so much, Dr. Pallavi, Dr. Poonam, sorry. And I welcome you, all of you, for this webinar on optimizing pregnancy care. And this is the first in a series that we are doing series of webinar with Integrace. And this January being the birth defect month. And we also have a focused webinar on birth defect because not all birth defects can be prevented, but we can actually do our best as an obstetrician to give a healthy outcome to our pregnant mothers, and that is the focus. And this focused webinar in January would be on birth defects. In February, we are going ahead with the cardiac anomalies, and in March, we'll be going ahead and doing with the Down syndrome. So this is first of its series. And this is actually the ISOPAP Mumbai chapter is a new chapter from few months ago under the able leadership of Dr. Suchitra Pandit Madam. And with her dynamism and with her encouragement, we are always trying to do all these new things, and we take all these new opportunities. And I'm very happy to welcome all of you. Dr. Suchitra Pandit Madam is here along with Secretary Dr. Rajendra Nagargatti, Dr. Ashwini Bhalera, our Vice President, is also here. So I welcome you all. And I also welcome Dr. P.K. Shah, sir, who is the expert and a guest of honor for today. And I welcome all the faculties who have logged in. And I would now like to invite our president, Dr. Suchitra Pandit, who requires actually no introduction, but Madam is always the charm of the ISOPAP Mumbai chapter. She was earlier the president of the main national ISOPAP, chairperson of the AICC RCOG, and the consultant at Surya Hospital, Mumbai. And she has led all the organizations at the top position, being it FOXY as a president, MOGS, FOXY representative to AOFOG, SEFOG, and also she is a great teacher and an academician for the last 33 years. Over to you, madam.
Thank you very much, Komal. First of all, I'd like to welcome all of you to our webinar. And in fact, this would be 6th or 7th webinar, Komal, if I'm to be corrected. And I'm so happy that, as neonates, we always have that enthusiasm to do a lot more. And I've got two lovely bubbling personalities with me to help me to execute that. And one is, of course, our Joint Secretary, Dr. Komal. And second is my secretary, Dr. Rajendra Nagarkatti. And of course, our entire support team, Urmila Surekha, Preeti Vyas, and two vice presidents, the very, very charming Reshma Dinopai, and the very, very dynamic um, uh, Ashwini Balirao Gandhi. I'm very happy that they have in turns been there to shape our new body, and I'm sure that hopefully we will get ourselves registered very soon, and we will do the work of spreading the knowledge of parentology and reproductive biology. Today, I'm very happy to say that, in fact, I was very keen to welcome our chief guest, Dr. Adi Dastur. He's a patron of MOGS and a life member of ISOPAR. But I think he's sent in his apologies because he's wanting to take rest. But I extend a very warm welcome to Dr. PK Shah, Professor PK Shah, who I've worked with as, once upon a time I was a lecturer and he was the associate professor. And then, of course, we worked together in MOGS and Foxy. Welcome, Dr. PK Shah, Professor and Unit Head, Department of OBGYN at the St. GS Medical College. And he was the past Dean of the Indian College of Medical Ultrasound, Indian Association of Gynecological Endoscopists, and the Federation of Obs and Gynae Societies of India. In fact, he was the Secretary General for 3 years before he got on to be the president. And of course, look at the associations that he's been associated with, be it IFUMB, be it the Association of Full-Time Teachers, KEM Hospital, or be it the Senior Medical Teachers Association. He's also been the past chairman of the Imaging Science Committee of Foxy, ISOPA West Zone, Joint Secretary of Images, Fellow of the WellStart International USA, Foxy representative to AFOG, past editor of the Journal of IFUMB, co-editor of OBGYN Journal Today, and member of the Safe Motherhood Committee of FIGO, as well as the USG Committee of AFOG, and of the Imaging Science Committee. So he's absolutely passionate about imaging science, and I think he's been a teacher to so many young postgraduates for the ultrasound. So it's really an honor to have you over here, Dr. PK Shah. And I'm sure, we'll be very happy to hear your expert comments. And has Dr. Parul Kotradawala also joined in? Do you know?
Yes, ma'am. Yes, ma'am.
Yes. So, Komal, will you introduce? Should I introduce it?
Yes, madam.
So, Parul Kotradawala, again, welcome Parul to this webinar of Mumbai chapter. Parul is the Vice President of ISOPAB. He's an endoscopic surgeon and a consultant gynecologist, and currently attached to the VS Hospital and the NHL Municipal Medical College at Ahmedabad, and of course Zydus Hospital, and he has his own clinic, the Kotradawala Women's Clinic. Vice Chairman of ICOG, Vice President of ISOPA, Vice President of Foxy, President of SOGOG and AOGS, and of course he's been the Managing Committee member of ISAR and IAG, and the Indian Coordinator of New European Surgical Academy, and Indian Coordinator of the International Adhesion Society. And Parul is a surgeon par excellence. Parul, welcome to this webinar.
Thank you.
So, may I request Dr. PK Shah to, give us blessings and advice for this particular chapter?
Thank you, Suchitra, for your kind words, and congratulations for doing such a fantastic job from different platforms. You know what COVID has done to us? We don't meet, but we see and talk to each other so many times. And the itch to teach has not gone amongst all of us. And that is what has survived all of us and has made lives of many Foxy members interesting. They are kept with the latest knowledge and the same topic being delivered by different people. And that makes a great comeback of teaching the way we are doing now for last 8 months. Maybe within a month or two, we will start actually having our conferences and we will be meeting. But till that time, let us enjoy these webinars. Thank you, ISOPAB Mumbai chapter, Suchitra, yourself, and Dr. Rajendra Nagarkatti, and also Dr. Komal Chavan, who is a convener, my co-guest of honor, Dr. Parul Kodrawala, who is reading his speech very seriously, and unfortunately we are missing a charming personality like Adi Dastur. We have a very good speaker in the form of Dr. Mandakini Pradhan, who will be speaking to us on role of folate in prevention of birth defects. And then Dr. Vanna Bansal and Dr. Raju Sahitya will be conducting a panel on screening and management of fetal anomalies. What is more important is we have a power-packed panelists in the form of Dr. Meenu Agarwal from Pune, Dr. Pooja Loda, Dr. Manjit Mehta, Dr. Archana Dwivedi, Dr. Ashwini Rathi, and Dr. Joy Mante. I'm sure today you are going to be given the first dose of this series on birth defects. And as Dr. Komal told us, that we will be getting the second and third dose in February and March. Am I right? So we will be vaccinated with this birth defect knowledge. So I wish the program a grand success, and I thank all of you for inviting me to be the guest of honor. Back to Komal or Suchitra, whosoever is. I think Suchitra, you have to do as a president of this organization, a lot of work.
Right. Thank you so much. Thank you for being there, Dr. Pikesha.
Yeah.
And Sion, and please give us your expert comments. And may I now request Dr. Parul Kotradawala as Vice President of ISOPAR to please say a few words.
Well, Dr. Suchitra, thank you very much. And I must compliment you and the team Mumbai for starting this chapter, which was long overdue, but perhaps Corona intervened, and maybe the parent large organization Foxy headquarters is in Mumbai, so most of the focus of activities are with Foxy. But it is time that we also have collaborative effort with other specialties also, and ISOPARB is a beautiful platform for that, to interact with pediatric colleagues and neonatologists. Dr. Pikesha, thank you for hitting under the belt. And I'm sure with 3 doses, we won't have lifetime immunity. So we'll need annual doses of this malformation issues.
Booster doses.
It is like flu virus. Every year it changes. Well, I wish this installation webinar all success, and I'm always there for any capacity to be part of your semi-webinar. Thank you.
Thank you so much, Parul, for being there. And, Komal, we must always ensure that our Vice President is there with us for all our activities. And even if he's not there in person, we must always make sure that, Parul knows about what's happening in our zone. Thank you very much, Parul, for being there. And I'm going to hand over the proceedings to you. But I'd just like to give a very warm welcome to Mandakini, to Vandana, to Raju, to all our panelists, Meenu, Pooja, Manjeet, Archana, Ashwini, and Zoe Manke. And I'm sure all of you all are going to enjoy this. And we have our 2 wonderful chairs, Ashwini and Urmila, who's going to be chairing the first session. So over to you, Komal, for the next proceedings.
Yeah, thank you very much, Madam. And Dr. Rajendra Nagarkatti, our secretary, is here. So I would like to, if you can give some few words. Dr. Nagarkatti.
Yeah, thank you, Dr. Komal. I just wanted to once again afford a warm welcome to the entire faculty and all the esteemed dignitaries here, including Dr. Pikesha, Dr. Parul Kotradawala, and of course we are missing Dr. Adi Dastur today, but we will again invite him in one of the next programs so that we can hear him talk. He's always such a lively personality, and it makes adds charm to the program. Once again, I wish to congratulate Dr. Suchitra Pandit ma'am for starting this chapter. I was prodded a lot, and I thank her for that. That ultimately we have started, and we are, as infants also, we are doing well. And of course, this particular dose of folic acid and its role in birth defects is very, very important. And I won't speak much. I won't remain between you and the speakers today. So I'll hand it over back to Dr. Komal, who's doing a wonderful job as Joint Secretary, and she's arranged so many programs. So congratulations, Dr. Komal. Great going, and please keep it up. So, and of course, a warm welcome to Dr. Ashwini, Madam, as Vice President of the Mumbai chapter, and of course, Dr. Rishma, and to Dr. Mandakini Pradhan, our prime speaker for today, and all the panelists and moderators. So thank you everyone for being here today, and over to you, Komal, again. Back. Thank you.
Thank you so much. And thank you, Dr. Suchitra Pandit Madam, Dr. Nagarkatti, President and Secretary, and our guest of honor, Dr. P.K. Shah and Dr. Parul Kutradawala. I extend a gratitude to all of you for being there for the inauguration of this focused webinar on birth defect. And it is brought to you. I thank our partners in it, the Science Integra, TOG team, and Integrace Pharma for this opportunity. And moving on now, we begin with our first talk by Dr. Mandakini Pradhan, who is the chairperson of the Genetic and the Fetal Medicine. And I call upon the chairpersons for the session, Dr. Ashwini Bhalerao Gandhi. Dr. Ashwini Bhalerao, may I have Madam's CV? And we know Madam is a very active person and very enthusiastic, and she has been the past president of Mumbai Society Obstetrics and Gynec Society, vice president of FOXY. She's currently the president of Mumbai Menopause Society, and she was an ex-professor at TN Medical College and Nair Hospital, and currently a consultant at PD Hinduja and Hinduja Healthcare Surgical Mumbai. And Madam is known for her immense work in adolescent health and in menopause, and Madam does all work with so much perfection. Welcome, Dr. Ashwini Bhalerao Gandhi, Madam, to this webinar. To join Dr. Ashwini Bhalerao, Madam, I call upon Dr. Urmila Surekha, who is also the treasurer of this ISOPAB Mumbai chapter, and she is a president-elect of Association of Fellow Gynecologists, member managing committee of the Society of the Vaginal Surgeries of India, an honorary gynecologist at Navneet High Tech Hospital and Manav Kalyan Kendra, and a gynecologist, director of Anand Nursing Home, director of Profert IVF, with a special interest in vaginal surgery, infertility. I welcome you, Madam, to chair this talk by Dr. Mandakini Pradhan. Over to you, Dr. Ashwini, Madam.
For introducing us, and I'm so happy that I'm present today for this webinar organized by ISOPAB Mumbai chapter. Dr. Parul, I follow always Dr. Parul's footsteps because he was the chairperson of Adolescent Health Committee of FOXY before me, and then I followed, and now he is vice president of ISOPAB Central. So I have become vice president of Mumbai ISOPAB, I think. So without wasting further time, can I go to Dr. Mandakini Pradhan's CV slide to introduce her? She's chairperson of Genetics and Fetal Medicine Committee of FOXY 2019 to 2021. She's professor and head of Department of Maternal and Reproductive Health at Lucknow, Uttar Pradesh, SDPGIMS. She has 66 publications in index journals. She has received Health Icon Award in 2018, Women Achiever Award 2018, ETV International Women Day Award 2018, Icon of Health Award 2017, and Ministry of Information and Technology Award of Hum Kisi Se Kam Nahi in 2016. And not only this, even she has bagged Governor Meritorious Award of 2008. I'm sure she's going to do a wonderful job of the presentation. All of us are very much interested in knowing what is the role of folate to prevent birth defects. nowadays, even lay people and lay women, they will ask us that which type of folic acid supplementation she should take, when she should start, how long she should take. So I'm sure you are going to guide us as well as the even lay public. Through us, they will get the proper message. Dr. Mandakini Pradhan, you can now start your lecture.
Dr. Mandakini Pradhan, Madam, we invite you to start your lecture, please.
Madam, unmute, yes.
Good afternoon, everyone. Hope you can see my screen.
No, your screen.
No, Madam, you have to share your screen, please.
Yeah, I did share. Not scared. Is it visible?
Yes, Madam.
Yeah, it's visible, ma'am.
Yes, Madam, it's visible.
So then done. So thank you, chairpersons. Thank you, Dr. Suchitra, for having faith in me that I can deliver this lecture. And thank you everyone for joining and then asking me to deliver something which I always love, because it is not because that I have made these slides, but because I get an opportunity to read something by making these slides. So welcome to this webinar, and a very good luck to this Mumbai chapter of ISOPAR. And all of us know that from treatment, we are now shifting our all explanation and everything. Our healthcare is moving towards prevention. And similarly, there was a day when we were looking into birth defects. Then early detection of birth defect, we moved from, say, second trimester to fourth trimester of birth defect. And then now we move on to the prevent the birth defect. So today I have been given the topic of role of folate. The moment this role of folate comes onto our mind, then we thought of, okay, folic acid prevents neural tube defect, that everybody knows, periconceptional folic acid. So there is nothing new, so I can finish this talk in one slide or two slides.
Ma'am, could you please do a slideshow, because we can just see the.
Okay. Yeah, done?
Yes, ma'am.
Okay. So this is, so everybody thinks that folic acid, so I will be talking on, everybody knows about neural tube defect. What is new in this? If Dr. Suchitra has selected one topic of folic acid and prevention of birth defect, there must be something new. So I digged into it, and then I also learned many things which are new. So neural tube defect, you may see in your scan, you may terminate a pregnancy with a neural tube defect, or sometimes you may see a baby who has got such a neural tube defect and can easily identify the clubfoot in this baby, and the prognosis being very dismal. Neurosurgeons are happy in repairing it, but long-term outcome is sometimes very good, sometimes doubtful. But how come folic acid came into this role? This was following this vitamin study, or what is called as a MRC study, or Medical Research Council vitamin study. This was published in 1991, and then following that, there was multiple recommendation to start folic acid, which prevents neural tube defect. So I digged into this MRC vitamin study group and thought to share it or revise it amongst all of us. So this was a randomized double-blind trial in 33 centers. There was 1,817 women were recruited with a previous history of neural tube defect. So all of us know that with a history of previous one neural tube defect, there is a risk of recurrence of 5%. So this was the high risk group for having neural tube defect. They were divided into 4 groups, and this was a double blind trial. So the patient did not know, and and the person who was distributing the medicine did not know. So the one group was folic acid, other group received other vitamins. The third group received both folic acid and vitamins, and the fourth group did not receive any medication or received the placebo. There were 1,195 pregnancy which were completed in this, and 27 patients had a recurrence of neural tube defect, 6 in the folic acid group and 21 in other groups. So the conclusion of the study was it is 72% protective. So hence the recommendation came that folic acid prevents around 70% recurrence of neural tube defect. But then while exploring this talk, I came across this article that is depicted on the left hand side, which was published in 2011, which says that folic acid supplementation and pregnancy more than just neural tube defect prevention. So then this article itself indicates that folic acid has got a role that is more than neural tube defect prevention. And the other article, which was published subsequently in 2013, so says that folate deficiency and folic acid supplementation, the prevention of neural tube defects and congenital heart defects. So the title itself says that it prevents neural tube defect and congenital heart defects if you supplement folic acid to a patient who or a woman who is planning pregnancy. My rest of the talks are from these two articles. Most of them are from these two articles. So coming on to congenital anomalies, this was WHO the publication on 1st of December 2020. So few days back only. So 2 months back only. And that says that newborn die, around 3 lakh newborn die worldwide within 28 days due to congenital anomaly. Severe congenital anomalies that they have included are heart defects, neural tube defect, and Down syndrome. All of us are very, very clear about, like these days, about Down syndrome, how to pick it so that we prevent the birth of a Down syndrome child. So if we can, with a simple methodology of giving folic acid, if we can prevent both neural tube defect and heart defects, then probably this severe congenital anomaly group will definitely decrease. And the anomalies, the causes could be genetic, infections, nutritional, and environmental. Most of us know that we are not very clear about the cause of congenital anomalies. Many of the times, like heart defects and neural tube defect, they are multifactorial in nature. That means multiple factors act together. And it says that this WHO bulletin says that some anomalies can be prevented by vaccination, folic acid supplementation, iodine fortification, and adequate antenatal care. We are already moving towards adequate antenatal care. Leave apart this COVID time when it is derailed. But then otherwise, if we look into the vaccination part, not the COVID vaccination, the rest of the vaccination, and folic acid and iodine fortification, probably we can prevent many of the severe congenital anomalies. So this is the bulletin that WHO has given in December 2020. So Benjamin Franklin rightly said that an ounce of prevention is worth a pound of cure. So if you can prevent birth of a neural tube defect child, so there won't be any this fetoscopic surgery of these neural tube defect, and fetal surgery probably will not have to be done. So I come on to what is recommended daily allowance of the nutrient. The amount of nutrients needed for maintenance of good health, and that is time to time recommended by Food and Nutrition Board of National Research Council. This is from USA. But excessive supplements during pregnancy may be potentially toxic and sometimes may be teratogenic. Toxic, like they have explained, iron, zinc, and selenium. I went and looked into the potential toxicity of iron. I did find that article of potential toxicity of iron. Vitamin A, we know about it. B6, C and D also can cause potentially toxic, and we all are aware about teratogenic effect of excess vitamin A in a dose of more than 10,000 international unit per day. So vitamin and minerals intake more than twice the RDA, that is recommended daily allowance, should be avoided, and that is both recommended by American Academy of Pediatrics and ACOG and as per 2007 guideline. So we should not exceed the recommended daily allowance twice the amount of this dose. So requirement of iron is increased during pregnancy, that is 2 to 3 fold. Requirement of folate increased by 10 to 20 fold, and B12 is increased by 2 fold. So what are the requirements? And that this the daily requirement I have taken from Institute of Medicine 2011, this thing that is on the left hand side, and the folate requirement there is mentioned as 600 microgram during pregnancy and 500 microgram during lactation. So simultaneously, if you look into WHO recommendation of dietary supplementation in pregnant women, it says that vitamin A is not recommended. D is need, this vitamin D supplementation needs a future research, whereas folic acid, iron and are strongly recommended during pregnancy, and calcium is recommended in regions with low intake, and India belongs to that area. So hence we say that calcium, folic acid and iron is recommended during pregnancy. So what is this folate? Folate is required for cell division and cell maintenance. It has got 3 specific role, that it acts as a coenzyme in the transfer and processing of 1 carbon unit. So what it does is it has an important role in thymidine synthesis, which is essential for repair of DNA. And as we know that DNA repair inside the cell, there occurs some repair mechanism of the DNA, so that the abnormal DNA are repaired during synthesis. So, and it is also a key factor in the site-specific methylation of cytosine base. So those cytosine, if methylated, makes the DNA silenced, or methylation is one of those mechanisms whereby folate acts by doing methylation of the cytosine, and remethylation of homocysteine to methionine is one of the factors that folic acid does. And we read about this cycle of folic acid intake converts into dihydrofolate and then tetrahydrofolate. This tetrahydrofolate gets converted into 5,10 methylene tetrahydrofolate, and with the enzyme MTHFR or methylene tetrahydrofolate reductase, it converts homocysteine to methionine, and hereby folic acid converts homocysteine to methionine. In absence of folic acid or in folic acid deficiency, homocysteine level increases because this step cannot be done. And we are aware about the MTHFR, that is the polymorphism of which is being tested routinely in the clinical practice. So folate is required for basically DNA repair and DNA gene expression in epigenetic or demethylation of homocysteine to methionine. What is the source? The sources are green leafy vegetables, citrus food, whole grains, legumes, foods fortified with folic acid, breads and cereals. There are countries where they have advocated fortification of food with folic acid, and nutritional sources alone are insufficient, and hence folic acid supplementation is recommended, and this I have taken from ACOG 2013. So folate deficiency in India is 25% of pregnant women in India are folate deficient. This article, I could not get into the detail of this article, only the abstract I could able to get. This the congenital malformation that folate deficiency can cause is neural tube defect that we saw, after that MRC trial. Then orofacial clefts, cardiac anomalies, anemia in the mother, spontaneous abortion, preeclampsia, then IUGR and abruptia placentae. Of course, we read about abruptia placentae, the causes of abruptia placentae. One of the causes is folic acid deficient. And those who have got previous history of abruptia placentae should be given pre-pregnancy folic acid to prevent recurrence of this condition. So folic acid supplementation is strong protective effect against neural tube defect, and that is more than 70% can be prevented. Then coming on to other congenital anomalies, that is congenital heart defects, the other article that shows that is a review article which has reviewed all those studies which has done the prevention of congenital heart defects in periconceptional folic acid supplementation. And the recommendation, the conclusion is that it prevents congenital heart defects, especially ventricular septal defect. Other defects it doesn't prevent. So especially ventricular septal defect, and as high as 40% prevention has been reported in that meta-analysis. Then coming on to orofacial defects and limb defects, though article says that it prevents orofacial clefts and limb defects, but exact percentage could not be ascertained. Then pediatric cancers like leukemia, pediatric brain tumors and neuroblastoma also are prevented by giving folic acid during pregnancy. This part we usually forget during our day-to-day practice. Coming on to, it could modulate other adverse pregnancy outcome. So hence, if we know that it prevents all these pregnancy related conditions, then probably we'll be very, very careful in giving folic acid. So it prevents seizures in women with epilepsy and seizure, pre-eclampsia and pregnant and even pregnant gestational hypertension. Then pregnancy induced anemia. Anemia could be because of folic acid deficiency, and pregnancy induced anemia is one of them. It prevents autism in the child, fetal growth restriction, and preterm delivery. So this I have taken from SOGC 2015, this thing. It is an important part of prenatal care of women with epilepsy. Why is anti-epileptic drugs, they act in folate metabolism. So folate decreased in these anti-epileptic drugs, and hence women with anti-epileptic drugs should be given higher amount of folate. It plays a role in reduction of the incidence of gestational hypertension and preeclampsia, because giving this correct hyperhomocystinemia the quantification and the exact studies I could not able to gather. It treats folate deficiency, and definitely folate deficiency anemia in pregnancies is prevented. It is of course generally safe. The potential side effect could be if we give folic acid simultaneously, so it is difficult to rule out vitamin B12 deficiency or vitamin B12 deficiency anemia. It interacts with drug that inhibit folate metabolism, decrease zinc absorption. Few people are hypersensitivity to this folate, associated with malignancy, neurotoxicity, epileptogenic effects, and increased susceptibility to malaria. This increased susceptibility to malaria is a concept that was even I did not know. While preparing these slides, I came to know that there was a study in Tanzania where they saw that those children who were supplemented with iron and folic acid, there the malaria severity was more and the death rate was more who received iron and folic acid. And hence SOGC recommends that in a malaria endemic area, if you are giving iron and folic acid, you must give malaria prophylaxis to these women. So folic acid effect on fetus is dosing above the recommended supplementation amount has not been shown to have any added fetal maternal health or developmental benefits. So hence it should be within the recommended supplementation amount and not more. In this epigenetic methylation study in animal and humans have indicated some caution and research is required. I am aware about one study that was published whereby they have shown that probably it may increase hyperactivity in the children in whom the mother received higher doses of folic acid. So folic acid doses more than 5 milligram is not recommended, but long-term high-dose 5 milligram folic acid use has not been well studied in prenatal population. And 2 studies, they have showed no association of colorectal adenoma and recurrence. This was a questionnaire that was raised that it may increase the risk of colorectal adenoma, but this has been futed. So on child, high doses of folic acid was associated with the increased rate of wheeze and respiratory infection, asthma medication among children, and bronchiolitic diagnosis. So this is in children, and hence using the lowest effective folic acid supplementation dose is required. There are a lot of articles in what is the dose that is to be given and when to start it. I have not included that in my lecture, but to inform you that the effective dose is 0.4 milligram. And if somebody is starting 0.4 milligram, it has to be started at least 3 months, because that amount of time is required to have RBC folate level. So red cell folate level to reach the therapeutic level takes 3 months. If you are increasing the dose to 4 milligram, it takes 2 weeks to reach. And hence, because 4 milligram tablet is not available, and hence we are left with 5 milligram tablet. So probably 5 milligram 1 month before planning pregnancy is the proper guide that we use and everybody practices. So what is the risk group classification by SOGC 2015 is, they have classified them into 5 risk groups. One is personal history or family history of other folate sensitive congenital anomaly like cardiac anomaly, limb defect, cleft palate, urinary tract, and congenital hydrocephalus. The category 2 is family history of neural tube defect in first or second degree relative. 3 is diabetes. 4th is medications that may involve or increase risk of neural tube defect. And 5th is GI malabsorption. Why they have done it is their recommendation depends on if there is any such family history that is there in the family. So they have categorized the risk group into low risk, moderate risk, and high risk. Low risk means there is no history on either side, on the woman or the husband or the wife. Moderate risk means women have one of those 5 scenario, and male partner has got scenario 1 or 2. If I go back to scenario 1 or 2, that says that family history of folate sensitive congenital anomaly and family history of first and second degree with neural tube defect. So if husband has got these 2 scenario, or wife is diabetes or anti-malarial, the medications, or the has got GI malabsorption condition, then that puts the condition into moderate risk. And what are high risk group are the male partner or the woman herself with a personal history of neural tube defect. If she herself had a history of neural tube defect and is repaired in the past, then that is high risk. So what is folic acid supplementation in the low risk? 0.4 milligram again. So 400 microgram 3 months before conception, so that RBC folate comes out to be normal, and that to be continued during pregnancy and in postpartum up to 4 to 6 weeks. In moderate risk, the dose is little higher, that is 1 milligram 3 months before conception, and it should be continued of first 3 months of pregnancy. Then you can reduce the dose, that is anyway comes along with the iron, and to be continued till 4 to 6 weeks postpartum. In high risk, the dose is increased from 1 milligram to 4 milligram, and hence the risk classification decides them. They advocate that those who fall onto the different risk category, the dose is to be the recommended dose is to be accordingly. And 4 milligram beginning at least 3 months before conception to be continued till 12 weeks. And then the dose can be reduced to the same that is there along with the iron dose and continued 4 to 6 weeks postpartum. So low risk, we know there is no history. Moderate risk, maternal history and paternal history of neural tube defect or any other malformation. And high risk, either the parent, either of them have got history of neural tube defect. So if the high risk, then only it is 4 milligram per day. So the recurrence risk for a fetus with neural tube defect is shared both by mother's and father's personal reproductive history. But only the mother is treated with supplemental dose of preconception or first trimester folic acid. Of course, there is no recommendation for father's folic acid. So the recommendation that SOGC have given with different evidence that women should be advised to maintain a healthy folate-rich diet, and folic acid multivitamin supplementation is needed to achieve the red cell folate levels. Then pregnancy are almost always unplanned, and hence they recommend to give it in all reproductive age group women who have their fertility preserved, that is between 12 to 45 years of age, and their pregnancy is possible. So folic acid supplementation is unlikely to mask vitamin B12 deficiency. There should not be any investigation to be done prior to initiating folic acid. So we should not start doing red cell folate level and then only do. So we should not carry this recommendation. Everybody should be blanketly to be given. It is recommended that folic acid to be taken in a multivitamin, including B12, and that can be given. So to conclude, folate in pregnancy is essential to prevent maternal and fetal abnormalities, not only neural tube defect but congenital heart defects and other pregnancy related complications like anemia, abruptio, preeclampsia can be prevented by giving folic acid. Dose is 4 milligram in high risk group and less in others. If less milligram tablet is available in India, probably we start giving less at least 3 months before planning pregnancy. But in endemic area of malaria, we need to treat malaria before giving iron and folic acid. I thank you once again, Dr. Komal, Dr. Suchitra, for giving me this opportunity, and thank you all who all are listening to this. And if any query, then I will be happy to answer, and I will be happy to be part of this subsequent the panel. That is, I'm looking forward to that panel. Thank you so much.
Thank you, Dr. Mandakini. It was excellent talk. Dr. Raju Sahitya has asked the question which you have already answered. What is a dose if it has to be continued throughout the pregnancy? Because before pregnancy, we give 5 milligram per day. But suppose we want to give throughout the pregnancy, then how low the dose can be?
Yeah, that is 0.4 milligram. That becomes 400 microgram. Yes. For all risk group. Only thing is that first 3 months, the SOGC has come up with this recommendation that in a high risk, you give 4 milligram. In a medium risk, you give 1 milligram. In a low risk, you give 0.4 milligram without any prior history. That is low risk.
Dr. Urmila, you will have to unmute yourself.
Thank you, Dr. Mandakini Pradhan, Madam. We welcome you from PGI Lucknow. You have wonderfully described the implications of folate deficiency. We need to start the folic acid 3 months prior to planning for a pregnancy, and as majority of the pregnancies may be unplanned to all the population who's planning to become pregnant, and the various dosage forms in the different groups which we need to identify and see that we give the appropriate dose. And after 3 months of pregnancy, we need to decrease the dose because giving higher dose of pregnancy can be harmful. Thank you very much, Madam. And now I hand over to Dr. Komal. Before that, I thank Dr. Suchitra Pandit Madam, Dr. Nagarkatti and Dr. Komal for allowing me to chair this session. And on behalf of Dr. Ashwini Bhalerao also, I thank you, Madam. Over to Dr. Komal Chauhan.
Thank you so much, Ashwini Bhalerao Madam and Dr. Urmila Surekha Madam. It was a wonderful session you have chaired, and definitely Dr. Mandakini Pradhan has done a justice and told us a lot of things about the folic acid, the dosage, and how to continue and everything. Thank you very much. It was an excellent session. And after this, we have a very interesting and a power-packed panel. And to moderate the panel, I will call upon our moderators, Dr. Vandana Bansal and Raju Sahitya, who would be doing justice to this very interesting topic, because we thought about birth defect and what best would be than screening and management of fetal anomalies. And to do this, I would call Dr. Vandana Bansal, Raju Sahitya. Can I have their CVs? And along with all the panelists, I welcome them. And this panel, not just with the moderators and the panelists, we have our very own, the expert of experts, the teachers of teachers, who is going to be the expert on the panel. And he's none other than Dr. Pikesha sir, who would be always going to give the expert comments and his the experiences, the vast experience and the immense knowledge he has in his subject. So Dr. Pikesha sir is always here and he's going to guide us throughout the panel. I welcome Dr. Pikesha sir as an expert for the panel. Thank you very much, sir, for waiting after being the guest of honor for today's program. Thank you so much.
And now I call there and Raju are there. They don't require any expert's opinion because both of them are excellent and experts. But whenever required, I'll open.
Thank you. Please do let us know.
Thank you so much, sir.
Can I share the screen?
Yes, you can share the screen. And I would now introduce Dr. Vandana Bansal and Dr. Raju Sahitya. Dr. Vandana Bansal, as we know, she is a member of Managing Committee of Mumbai Obstetrics and Gynec Society. And she has an immense work in perinatology. And she is an consultant, a fetal medicine expert and director, head of the Surya Fetal Medicine Center in Mumbai. And she has expertise in diagnostic and therapeutic fetal intervention. And MUH's approved faculty for fellowship program in fetal medicine. She has numerous papers and a lot of publications on this subject. So she has a vast knowledge of this subject. Welcome, Dr. Vandana Bansal. And to join Dr. Vandana Bansal, I call upon Dr. Raju Sahitya. Dr. Raju Sahitya is a Vice President of AFG, President of ISPA 2014-16. He's also the Executive Managing Council, member of the Mumbai Obstetrics Gynec Society, with a special interest in reproductive and fetal medicine. So these two moderators are definitely going to do an excellent job. And with all the panelists, I welcome them all and hand over the job to the moderators to welcome our panelists, introduce them formally, and begin with the panel. Thank you.
Thank you so much for the kind introduction. And Vandana and I will be going through this panel with you all on screening, diagnosis, and management of fetal anomalies. And I thank Indian Society for Perinatology and Reproductive Biology to give us this opportunity. Okay, I thank President Suchitra, the Secretary Rajendra Nagarkatti, my friend Komal Chauhan, my dear friend Adi Dastur, who is not here, and the other guest of honor who's here and is going to be an expert to our panel, Dr. Pikesha. Dr. Parul left, he said he's got some other commitment. And above all, I congratulate and thank all these panelists who are going to be with us for this program. So I'm going to begin by an introduction already done. The paradigm shift. Only in the past few decades has the fetus been considered as a patient and become the subject of extensive scientific study and attempts at treatment. Technological advances have facilitated our ability to assess and manipulate the fetus. So today,
Dr. Sahitya, I'll just interrupt because we have our panelists and I thought we would just introduce them with few lines. So we have an esteemed panel here And I welcome on the panel Dr. Meenu Agarwal, who is the chairperson of the Ultrasound Imaging Science Committee of FOXI. And along with her, I call upon Dr. Ashwini Rathi, who is a fetal medicine expert and who is a practicing fetal medicine specialty in the city of Mumbai. She's our very own ISOPAB member. Dr. Manjeet Mehta, who is also from the ISPAT Society and has specialized in fetal medicine. So welcome, Dr. Manjeet Mehta. And I also like to welcome Dr. Juhi Manke. Dr. Juhi Manke is the pediatric surgeon on the panel, and she is definitely going to go more into the treatment part of the panel. So welcome. It's very nice to connect with you, Dr. Juhi Manke. And none other than, apart from all that, we have our very own Dr. Archana Dwivedi, and she has also immense knowledge in ultrasound and her specialty being her special interest being in ultrasound. And Dr. Archana Dwivedi also is a wonderful person and a great human being and a great friend. So I think I've introduced all because I can see them.
Dr. Pooja Lodha.
Yeah. So I think now welcome all the panelists, and I will hand over to Dr. Raju Sahitya to go ahead and make the panelists comfortable and start with the discussion.
Thank you, Komal. I was to introduce them little later. It was coming. I have put it in such a way.
Okay.
Introduced,
I really thought they should be comfortable.
You made
my
job simpler. Thank you so much.
Thank you.
Today's learning will be what are birth defects, what is the incidence, any pointers in history, define prenatal screening and diagnosis, what are the methods of screening, what are the methods of diagnosis, how do you calculate the risk. This is very important because when we see a report, we don't know how to calculate this risk, and evaluation and investigation and any pointers to prognosis. We are going to do this in two half with no interval between. Interval be only changing of the screen sharing. The first half is going to be the brainstorming, and the second half is going to be the case scenarios. So we will start with the brainstorming. And, let us first understand the history of prenatal diagnosis. It all started with just thinking that family history and maternal age is of the utmost important thing way back in the 80s. But when the ultrasound came, which was introduced in 1970, it made all the difference. And the first done amniocentesis for chromosomal studies was in 1966, but it became more common and acceptable after the advent of ultrasound. Then came the chorionic villus sampling, which got greater importance and acceptance in the 80s and 90s. Thereafter, we all know the expansion of serum markers, the ultrasound screening, and widespread use from the 1990s to the present times. So prenatal diagnosis saw the difference, and the landmark was the introduction of ultrasound, a true revolution in two respects. For the doctor, it allowed to diagnose in fetal life problems that until then had been only known in the newborn. For the parents, it facilitated the recognition of fetus as the person. When we talk about fetus as a person, in the development of a new concept, the fetus as a patient, and with it, a subspecialty, fetal medicine. A specialty in its own right, and it helped in the preventive, supportive, and curative of the unborn. And this is all what the fetal medicine specialists know and do. Find the natural history, accurate diagnosis, obstetric decision-making, counseling, workup, offer treatment in specific cases. It has always been a multi-speciality approach. And like what Komal said, we have today with us expert panelists who are also multi-speciality and they come together to do this program. We have Meenu Agarwal, who is a chairperson, Imaging Science Committee, FOXI, 2018-20. Pooja Lodha couldn't join us for some medical emergency. Then we have with us Dr. Ashwini Rathi, who practices fetal medicine. We have Dr. Juhi Manke, who is a pediatric surgeon. Then we have Manjeet Mehta, a consultant reproductive geneticist who's there with us, and Archana Dwivedi. She is a senior gynecologist practicing at Sterling Hospital. So these are the introductions which were to follow, and you can see them. So what is birth defect? May I ask Dr. Manjeet Mehta to tell us what is birth defect?
Good evening, everybody. At the outset, let me thank Dr. Komal Chavan for inviting me for this webinar, and congratulations to ISOPAB team, especially Dr. Suchitra Pandit, Dr. Nagar Katti, Dr. Ashwini, and Dr. Parul for the beginning of the Mumbai chapter. A birth defect, we could say, is any kind of a structural change that we see at birth. It could affect any part of the body. Anything, I mean, it could be something to do with the heart, the brain, the foot, any extreme of the body. Birth defect may be externally visible, or it may be something to do with some body function. They could range from mild to severe. As you can see, there are more than 4,000 different known birth defects, which have been documented in history. These birth defects could be inherited, they could be de novo, they could be caused due to the genotype of the fetus, they could be due to some infection or any antenatal exposure to toxins. And examples, you can say heart disease, cleft lip. Some of them are really very severe. They cause infant morbidity and mortality, and a significant cause of premature death and long-term disability. So it's quite a comprehensive term.
Ashwini Rathi, what is the risk of having a fetus with an abnormality?
Good evening, everyone. So the risk factors for having a fetus with abnormality could be divided as genetic and environmental. Genetic, because our population is also quite a bit of consanguinity is prevalent. So that also adds to the risk. Amongst environmental factors, we have the socioeconomic factors, demographics, maternal age, of course, comes into the picture. Then exposure to a couple of toxins, alcohol, tobacco, the certain drugs that ladies are taking for pre-existing conditions. Of course, we have infections like rubella, toxoplasmosis, CMV. So those could be overall risk factors for a fetus with abnormality.
Dr. Archana, what is the purpose of prenatal screening?
So as you already said, now fetus can be taken up as a patient itself, because quality of life is a very important thing. We should aim as an obstetrician and a fetal medicine expert together. So prenatal screening offers you to decide a better fetus in womb if you have come before the counseling, so that we can look into the history of the patient and also see the other genetic aspects of the before planning the pregnancy, to diagnose a child which has got a better survival rate and a better quality of life in the later on this thing. Here where we can have a comprehensive approach, that we know what is the family history of the patient before they are trying to conceive, the paternal history, detecting the genetic abnormalities associated with that patients, and reducing the chances of birth defects. And ethical, and there are so many medical issues which can be taken care of at this point of time where the patient is coming into the contact with us, because appropriate advice and appropriate counseling given in a right way will give rise to a healthy parenthood and prevent the birth defects later on in the pregnancy and her delivery career and so on. And we give a better prognosis to the fetal surgeon in the panel, so that we have a better outcome in terms of a healthy lifestyle.
Pooja is not here. I would just say that the concept of screening involves that it should be universal, and the entire pregnant women population should be screened. And then you should come to know whether it's high risk or low risk. Of course, if it is high risk, you have to go in for diagnostic, like amniocentesis, CVS, or fetal blood sampling. And if it is low risk, you can follow them as routine cases. Dr. Meenu Agarwal, what are the prenatal screening and diagnostic timeline? Meenu, are you there?
Yeah. So when we say prenatal screening, it has 3 legs. One is your biochemical screening, one is the ultrasound, and one is, of course, non-invasive, which is like a NIPT. When we say timeline, we can do it in the first trimester, that means between 11 weeks to 13.5 weeks. Then we can do it in the second trimester, that is in the 17 to 21 weeks. But with ultrasound, you can do, I mean, at any age of the fetus, whenever we are doing anomaly scan, even at 26 weeks, 28 weeks, we must look for if there's any anomaly and then comment on it.
So remember that always offer, suggest, recommend. Screening tests have to be offered. Present something which is available with you. Don't speak about something which is not possible. Diagnostic tests always should be suggested, and you should let the patient decide for themselves after understanding. You should not have a direct telling them to counsel them to do the test. And carrier parents should be recommended and advised in which the person will be benefited. Archana?
Yes.
What do you mean by inverted pyramid of prenatal care?
So this is the modern pyramid, not like the age-old thing which we were conventionally dividing, come after 4 weeks, come at this week, we'll only do the diabetic screening and do the FHS in this monitoring. This is a more comprehensive and a patient-oriented pyramid, where the first point of contact, where we can detect the maximum chances of aneuploidies, that is 11 to 14 weeks, as you have shown in the triangle very well, that at 12 weeks, we can segregate the patient who have got low risk and who have got a high risk. So once at low risk, they can be again called at 20 weeks, again screened for the preeclampsia, the diabetic screening, and the high level 2 ultrasound, and then they can be called back on 37 weeks and follow up at 41 weeks SOS. But when we get a group or the cohort which needs a specialized care and a more close monitoring, that can be monitored from 12 to 34 weeks till they progress to 41 weeks. So I feel this is the invert pyramid concept has introduced a comprehensive care and a better outcome in terms of perinatal and maternal outcomes. So this is the way it can be defined.
Dr. Meenu Agarwal,
Yeah.
be done prior to conception.
After Dr. Mandakini's very excellent lecture, of course, folic acid, we have to start when they come to us and they say we are planning a pregnancy. Whether she's a diabetic or not, we must know, and we must make sure that her sugars are under control. Then if she has any thyroid disorder, that also should be brought under control. And again, if she's on any kind of medication, any antidepressants, any kind of, sometimes they're into also young, generation, sometimes they're also into smoking, drugs, alcohol, all that should be stopped when they go to us. And of course, if there is a family history or if there is a previous history of an affected child, then that should be taken into consideration, and then we have to counsel them and go for any test. Suppose she's for IVF, she's the older age group, maybe we might go for a aneuploid screening on the PGS on the embryos. And of course, all this rest you have already mentioned here, Dr. Raju.
What are the options during pregnancy? Can I ask Dr. Ashwini Rathi?
Sir, options during pregnancy for screening. All right, okay. So the options of aneuploidy screening or any congenital malformation are two, basically screening versus diagnostic. The most important point that we need to convey to the couple who's coming to us is whether they are undergoing a screening test is what comes after the result of the screening test. What is going to happen if they are coming out as high risk? And if they are willing to accept the next step of taking up the invasive testing or the diagnostic testing, then they are to be offered the screening testing. So those are the options, and they are all to be offered with adequate pre-test and post-test counseling, so that they are empowered to take the right decision, and we are not deciding for them.
So for screening, the risk evaluators in prenatal screening is finding out whether the person is the high risk for chromosomal abnormality or structural abnormality. And I will again ask Ashwini, What is a screening test?
Right. Okay. So a screening test is a test that is applied to a completely healthy population. So a nascent population. The screening test's objective is to segregate this population into two groups, into a low risk group and a high risk group. Then you have to further on explain the high risk group for the diagnostic testing. The purpose of a screening test is not diagnosis at all. It is to reassure a majority of the population that you are in the low risk group and select a few who will then go on to require further tests.
So screening for abnormality mainly considers maternal age, the maternal serum markers, ultrasonography, and combined screening. Dr. Manjeet Mehta, what is the age risk for fetal aneuploidies?
So it is very well known that the greater the maternal age, the higher the risk of aneuploidies, starting with Down syndrome, but even also including trisomy 13 and 18 and sex chromosome abnormalities. It is also known that paternal age does play a role in increasing the risk factor for aneuploid fetuses. This is because of a biological process known as non-disjunction, which happens at the time of cell division, wherein one of the chromosomes, they just lag behind. That's known as anaphase lag. And then, one cell gets one additional chromosome and the other cell, because it has a less chromosome, it dies off. And as you can see at the various ages, the risk of having a fetus with an aneuploidy are very clearly shown in this graphical representation.
Ashwini Rathi, what screening tests are available?
Right. So I will divide them into trimesters. So in the first trimester, we have the combined first trimester screening, which is a combination of the NT scan done at 11 to 13.6 weeks, along with the dual marker, which is the beta HCG and the PAPI. As we move on to the second trimester, certain biochemistry tests like quadruple markers are available. And of course, the most important one currently, the non-invasive prenatal screening with the cell-free fetal DNA, which can be done anytime after 9 weeks of pregnancy. So these are the screening tests available with us.
So where are these analytes coming from? This picture is very clearly showing the nuclear translucency, the unconjugated estriol, the alpha-fetoprotein, the HCG, the inhibin A, and PAPA. And aneuploidy pregnancies, like what Ashwini said, are associated with altered maternal serum concentration of various fetoplacental products. Dr. Pooja is not here. I think I will take help of Dr. Ashwini Rathi here again. First trimester combined screening.
Right. Okay. So the backbone of Down syndrome screening currently should be offered to everybody, irrespective of the age. We do the NT scan between 11 to 13.6 weeks, and the dual marker is also done simultaneously. Beta HCG and PAPA are measured, and a combined result is then given to the patient. Why this has become the backbone? Because it is good, very efficient in what it has to do. It will pick up, if it is done appropriately, almost 90-95% of Downs with a false positive rate of 5%.
Dr. Meenu Agarwal, second trimester biochemical screening.
Okay, I would like to also add in the previous question that at our center, we do PLGF and uterine artery Doppler as a part of the first trimester screening, because we feel we can pick up patients who might develop PIH or early preeclampsia.
Very true, very true. That's what is done. In recent times, we have started doing that. Yeah.
And second trimester, of course, we'll go for a quadruple test. And in the quadruple test, we can pick up Down syndrome, especially when we do quadruple tests. Sometimes especially this lockdown period, many patients had missed their first trimester screening. So they are coming 16 weeks, 17 weeks, and they're getting more time with each other. So they are actually coming pregnant when they were trying to conceive earlier and they were not getting pregnant. So these patients, we go for quadruple test, or sometimes if your double marker test is borderline. So you give them the option, they don't want to go for NIPT, they don't want to go for invasive test, then sometimes we also go for quadruple test. So this will tell us again the risk of Down syndrome, risk of neural tube defects, and also sometimes the risk of IUGR, because here we have alpha fetoproteins. That will also give you some risk of whether the patient might have an IUGR later on.
Dr. Archana.
Yes, sir.
Screening detection rate.
So when it should be done, the detection rate, if we do it in first trimester, that is, Madam rightly said that 10 to 13.6 or 14 weeks. As you can see, the slide itself is very well predicted that 83 to 80% we can detect the trisomy 21 and trisomy 18. With a good ultrasound backup, the ratio and the percentage increases. Quadruple screening test can be offered from 14 to 22 weeks and with a high probability of neural tube defects, almost 80 to 90%. And the integrated screening, that is first trimester screening of ultrasound with quadruple screening. When we do it at 10 to 14 weeks, the trisomy 21 pickup is high, and between 16 to 22 weeks, the neural tube defects are readily picked up, along with trisomy 18 also. Now, when we combine the NIPT test along with maternal serum testing, less than 9 weeks, other aneuploidy screenings also, along with Down syndrome, the probability of detecting it is more than 99% around. That is a very good time where we can offer the prenatal counseling to the patients. So with NIPT in picture, though costly, we are having a better screening rates.
Dr. Manjeet Mehta, what is NIPT?
So NIPT or non-invasive prenatal testing is also known as non-invasive prenatal screening, because ultimately, although it is a very high sensitivity, it is a screening test. And a word of caution that no decision on the termination of pregnancy should be made based on the results of this test. It has to be confirmed with an invasive procedure. This is non-invasive because we are collecting the mother's blood from a peripheral vein, and from them we are able to isolate some fetal cells, which we are testing by various methods like whole genome sequencing, SNP arrays, and Sanger sequencing. There are sequencing methods because this fetal DNA is circulating in the mother's blood, and we calculate the fetal fraction from this, and that is how we are able to give a very sensitive and almost accurate risk estimation of having an abnormal fetus.
This you already answered. NIPT is done on fetal DNA. So can it be a diagnostic test for aneuploidy? You said no. It's a good screening test. These are the consideration if you would like to cover up the indication and contraindication.
Yeah, so we can do NIPT in a singleton pregnancy or in a twin pregnancy, but if there are more than more than two fetuses, it is contraindicated. Maternal obesity also does come in the way of this getting the right fetal fraction. And if there is a high risk on either a screening test or an ultrasound, we are able to pick up something, then we should go in for this. If you see something which is confirmed, which is almost sure, even without doing an NIPT, it's better to go in directly for the invasive testing. And we cannot pick up other abnormalities rather than besides these common the aneuploidies and the few microdeletions for which there's a commercial assay available. We are not able to be very sure about the mosaicism, if it will be confined to the placenta or if it will be present in the fetus itself also. And then in certain labs, they have their cutoff of fetal fraction, some say 3%, some say 5%. So below that, we cannot proceed with the test.
So it's very important to have the right fetal fraction to get the results. Dr. Ashwini Rathi, association of fetal heart rate with aneuploidy.
So the fetal heart rate increases steadily from 110 to 170 between 5 and 10 weeks. A certain percentage of aneuploid fetuses will have variations in their heart rate. In trisomy 21, about 15% of fetuses will have the heart rate which is a bit on the higher side, but this is more pronouncedly seen in trisomy 13 and 18. In trisomy 18, about 15% of fetuses will have a heart rate which is lower than 5th centile, whereas in trisomy 13, tachycardia is more commonly seen, whereby almost 85% of fetuses are having a heart rate of above 170. So this can help us as an additional marker.
The ACOG stand on prenatal screening and diagnosis is as what you can see here. All women should be offered aneuploidy screening before 20 weeks, regardless of the maternal age. So it is universal. All women should have the option of invasive testing regardless of age. Earlier, it was just age which took them to the invasive. Primary provider should be able to discuss the detection rates, false positive rates, disadvantages, and limitation to the tests. How is ultrasound used for screening and diagnosis? Dr. Ashwini Rathi.
All right. Okay. So ultrasound is again very crucial to the entire aneuploidy screening program. It comes into place in two important trimesters. The first trimester is the NT scan, done at 11 to 13.6 weeks. We need to take a look at the NT, the nasal bone, the ductus venosus, tricuspid regurgitation, the FHR. So all of these markers put together will give us a very high detection rate. Apart from aneuploidies, our NT scan will also help us diagnose many malformations right away in the first trimester itself. And also, of course, we'll do our uterine artery Dopplers and screen the lady for hypertensive disorders later on. The second juncture where the ultrasound comes into picture is the anomaly scan. And of course, also in diagnostic procedures.
Dr. Ashwini, I would like you to take up this question also. NT scan based screening results, how do you proceed? What is the protocol?
Right. Okay. So the combined first trimester screening result should be considered, not just the isolated NT or not the isolated dual marker. So when we have a combined result of the NT scan where all the other markers are also preferably done, like the nasal bone, ductus venosus, tricuspid, all of those. If we have a low risk result, which is defined as less than 1 in 1,000, we can reasonably reassure the family and call them back directly for the anomaly scan. If we are in the high risk category, which is less than 1 in 250 as far as Down syndrome is concerned, they will be further guided up along depending on whether they want to choose the NIPS or the invasive testing. The intermediate risk category, which is being increasingly highlighted between 1 in 250 to 1 in 1,000, would generally again be counseled, and NIPS seems to be a good option for this intermediate risk category, especially if the risk is only biochemistry based, the NT scan being completely normal.
Dr. Meenu Agarwal, what about the nasal bone and its use for screening?
See, nasal bone, normally we would find a nasal bone when we are doing a first trimester screening, but sometimes we may find that the nasal bone is absent. If you are not able to see the nasal bone or the nasal bone is absent, I think we can call the patient back after 4 weeks. Many times you see the nasal bone in your second scanning, and you unnecessarily don't make the patient anxious. But if it is absent along with the thickness, nuchal thickness is also more, then maybe you can go in for either NIPS or go in for an invasive testing. Dr. Pikesha, if you have some comment on this, you can please. I would repeat that scanning after 4 weeks.
I think that's a good suggestion, Raju. Many times it is not absent nasal bone alone.
I'm not able to see.
So what is important is hypoplasia. Hypoplastic nasal bone is also equally important. And we have now the chart available for the length of the nasal bone at different weeks of gestation. And you have to follow that. And I think there is no emergency. You can always call the patient after some time and see whether the nasal bone appears or not. As you have very rightly shown, that up to 3% of euploid fetuses, normal fetuses also can have absent nasal bone. So you have to keep that thing also in mind and counsel the patient and her relatives accordingly.
Very well covered, both of you, because if everything else is fine, NT is fine, and you don't see the nasal bone, it's not that there is a problem. You can always follow up after 4 weeks. Dr. Ashwini Rathi, once again, these are the other markers which she spoke of. If there is anything in particular you want to say, or I'll go to the next slide.
Only thing that tricuspid regurgitation and ductus venosus, apart from aneuploidies, would also flag off for congenital heart defects. So if we have an isolated DV that is absent or reversed, or a tricuspid regurgitation, I would want to call them back at around 16 weeks and take a second look at the heart for early detection of congenital heart defects.
Dr. Jui Manke, finally, I have to call you now, and welcome to this panel, and we need to know from you. This is a normal fetus. What do you see here? If you could describe it briefly.
This seems to be a normal fetus. There is a fine seen, 34 weeks gestation, but there is no brain seen on one side. So it is an anencephaly.
Very well diagnosed. So you also gave the markers how to diagnose. Let's get to the other one. Dr. Archana, what do you see here?
So this is a multifetal gestation. Here we can see the twin pregnancy, and here we have got a set of 5. This
1, 2, 3, 4, 5.
1, 2, 3, 4, 5. And the chorionicity, as you can say, this is the sign where we can see the dye, this thing, and there, this is a very right time where we should predict the chorionicity. I'll take a word on that. That this can determine the later on, like ETTS and all those things, where the chronicity is very important to detect at this point of time. So this is a case which needs a very close monitoring and follow up later on. Yes, sir, you saying something? Close monitoring and follow up later on.
Yeah. Dr. Meenu Agarwal, second trimester ultrasound, what all you can see?
First of all, most of the times you will see a normal fetus. So we will see a normal fetus with no problems, but rarely we can see some lethal abnormalities which were not diagnosed in the first trimester. So anencephaly, most of the times will have been diagnosed in the first trimester. Then skeletal dysplasias, renal agenesis, then congenital diaphragmatic hernia, heart defects, neural tube defects, then omphalocele, and any herniation of the abdominal wall. Rarely, less common abnormalities will be, you see 6 fingers or polydactyly, club foot, or a cleft lip or a cleft palate. So you have to look for all these abnormalities. Most of the times, everything will be fine. But you have to make a list, tick mark that you don't see this, don't see this, don't see this, don't see this. And if your ultrasonologist or your fetal medicine specialist is given you these tick marks, tick in the box of all of these, you are comfortable as an obstetrician that yes, everything is fine with the baby, rather than just putting no obvious anomalies seen.
That's great. Dr. Juhi.
Yes.
You are seeing these images. Now, could you tell us how to read these images?
So, firstly, you have to look at whether broadly all parts of the fetus are looking in a normal position and are looking normal. If the brain is not seen, then you have to look at the spine to see if there is any neural tube defect, whether there is any swelling like a meningomyelocele seen, whether the bladder can be seen in that case. And then they all get related to 2-3 things. One is the brain, the spinal cord, the neurogenic. So you're looking at the bladder, then you look at the heart, because they all may be affected in this case. This looks like an anencephaly.
That's right. Dr. Ashwini Rathi.
This is
Dr. Ashwini Rathi.
Yes, sir.
How do you read this?
Sir, we are seeing a sagittal section of the fetal spine. In the lumbar region, we have a discontinuity. We also have a kyphoscoliotic gibbous-like formation, most suggestive of an open neural tube defect, most commonly seen in the lumbosacral spine. I would also want to see the axial planes of the brain to know if there is posterior fossa herniation, Arnold-Chiari malformation.
That's right. Dr. Juhi.
Yes. This is obviously the first image is a ultrasonographic image of intestines which are outside the abdomen. And when this is born, this looks like a gastroschisis, which is the intestine which has failed to return back into the abdominal cavity, and there is a defect to at the right of the umbilical cord. So this constitutes a pediatric surgeon to be there during delivery, so that there are two ways to deal with it. Either we take an adjoining table and return it back immediately depending on how the general condition of the baby is, or we apply a silo and wait for some time.
Great. Can I make a comment, Raju?
Yeah, please go ahead.
Just go to previous slide, please.
This one?
Previous. Now, see, it is very easy now because he has shown you the neural tube defect is written, and that you can see curvature and kyphoscoliosis and all that. But what happens when a gynecologist starts with looking at the spine? He starts from the cervical spine, comes to thorax and upper lumbar, and then he feels that everything is all right. Let me tell you, gynecologists and sonologists, I am not blaming anyone at all. We are also equally bad at it. You must go right up to the sacrum. Make it a habit. Even if you feel that everything is normal, unless you reach the sacrum, don't call it a day saying that everything is all right. We have seen many times people have missed small defect in the lumbar region and sacral region. And even that includes good sonologists. It is not done purposely, but because of lack of time. Let me tell you, you want to finish it off. You want to do ultrasound and you want to finish it off fast. Never do that. Please do it very seriously and religiously. Yeah, go ahead, Raju.
Thank you for the comment. And now we are here. Again, Dr. Juhi is going to read this for us, and we make a diagnosis.
This looks like a bilateral cleft cleft lip. However, we will have to, I can't make out whether it is a cleft palate also or not.
Okay.
So it looks like a bilateral cleft palate. The lip will have to be repaired earlier. The palate repair will come quite late.
Can I make a comment?
Yeah, please, come in.
So if the cleft palate is diagnosed antenatally, it is very important that the mother should not feed the baby, because that feeding has to be, otherwise, the baby will aspirate.
That's true. This is very obvious. It's clubfoot and Juhi, sorry. Go ahead.
No, it is very obvious. It is a clubfoot and polydactyly.
Okay.
So, actually, interestingly, some parents tend to consider a polydactyly as a good omen, and they don't want us to operate on it.
Is it called Ritik sign?
And a clubfoot requires a good pediatric orthopedic surgeon who will give us splinting earlier and then see whether it corrects or it will need a soft tissue release later.
Thank you. So screening, final results of genetic sonogram test could be high risk, could be low risk. We have to always remember, after all, it's a screen. Although imaging is advanced so much, as good as diagnosis, but it is a screening test and not a diagnosis. So these are all the things which you can pick up on sonography. And so what is the diagnostic test? Pooja is not here. I would request Dr. Ashwini Rathi.
All right. Okay. So diagnostic tests are invasive tests, depending on the trimester in which we are. In the first trimester, if we are doing a diagnostic test that is called the CVS, the Coriolis sampling, to be done anytime after 11 weeks, because done prior to that, it increases the risk of transverse limb defects. So between 11 to 13 to 14 weeks max, we have the window for Coriolis sampling, where we are taking a small tissue of the placenta. Whereas in the second trimester, after 16 weeks onwards, if an invasive test is being done, it's the amniocentesis, whereby a needle is introduced in the amniotic sac and about 20 cc fluid is drawn and sent for testing. We also have the option of fetal blood sampling. More than about 18 weeks onwards, we can opt for the fetal blood sampling, where a needle is introduced into the umbilical vein and then some amount of blood is aspirated. And invasive tests are inherently associated with a small risk of miscarriage, quoted about 1 in 300, 0.3%.
That's great. So with all this paradigm shift to non-invasive, will invasive procedure disappear? Anybody can answer this. Will invasive procedures disappear?
No.
No, definitely not.
The reasons for that?
The non-invasive prenatal screenings are not capable of diagnosing single gene defects. Also, if we are seeing malformations on the scan, we would want to have a more detailed genetic gene level diagnosis in terms of arrays and exomes, which the NIPS is, with the current technology, not able to give us.
So these invasive tests are always going to be there. Some people think that because of non-invasive, the number of patients who undergo invasive tests have reduced. But as a matter of fact, since there is universal screening, and we know that younger pregnant women are more than 70% and older than 30%, therefore requirement for invasive tests in fact has increased because a bigger population is being screened, and those which are seen to be at high risk deserve invasive prenatal diagnosis. What is chorionic villus sampling? Ashwini.
Right. So chorion villus sampling is basically an invasive test, as I said before, done between 11 to 13 weeks. With local anesthesia given, the needle is inserted into the placenta and a few villi are aspirated. Cannot be done before 11 weeks. Usually not done after 13 to 14 weeks. Because then we have the option of the amniocentesis. The advantage is earlier diagnosis, because in the first trimester itself you have the answers. The disadvantage are, of course, the inherent small risk of miscarriage, 0.3%, and placental mosaicism, whereby the karyotype of the few cells in the placenta is different from that in the fetus. So in these cases, the CVS could be misleading, and then we should opt for the
If you could continue and tell us about amniocentesis as well.
So amniocentesis is the diagnostic test done after 16 weeks. No local anesthesia is required. The needle is inserted into amniotic sac. Fluid is sent out for genetic testing. Advantage, it's a diagnostic test. It will, of course, answer all the questions related to the aneuploidies. Disadvantage, a small risk of miscarriage, 0.3%. The fetal blood, sorry, I think it's getting monotonous. If anyone wants to take that up, I'm happy.
You please
I
tell
continue.
us briefly.
All
Tell
right.
us briefly.
Okay. All right. Okay. So fetal blood sampling done after 18 weeks of gestation. The needle is introduced into the umbilical vein, and a small amount is taken up, mainly in terms of investigations for fetal anemia, either immune or non-immune. Even in terms of the investigation for thrombocytopenia and certain congenital infections. The fetal blood sampling is done. The associated miscarriage risk is slightly higher, around 3 to 5%. So that's about fetal blood sampling.
So the role of fetal blood sampling now is more towards therapy. Otherwise, the procedure is not so very often done. Only when CVS or ultrasound and amniocentesis are inconclusive, you may require to do fetal chordosynthesis. So this is how it is. So breaking the bad news. Manjeet, how would, as a geneticist, you would tackle this situation when you have to tell the patient?
So, as a geneticist, it's really very important for a person to understand the genetic basis of disease, the genotype-phenotype correlation, also to be updated about the latest tests. What are the various technologies coming in today? I mean, we are spoiled for, choice of different technologies. Each of them have their own reach, have their own limitations, have their own sensitivity. So geneticists, when they are talking to the couple and interacting with them, has to have an in-depth knowledge of all of this. Also the availability of which test is available where. Because Dr. Ashwini has very nicely elaborated what are the various tissues which the obstetrician or the fetal medicine expert is aspirating, or sampling. But then that tissue, that sample has to be sent for some test. So which is the right test for the person, which condition can be picked up by which test is really very important.
And how do you break the bad news? How do you break
so the psychosocial part of it, the people come with a lot of emotional factors. They are in denial, they are in guilt, they have hostility, they are mourning, they are in grief. So all this compassionate part has also to be taken care of by the genetic counselor or the social worker, because it covers the psychosocial counseling also. There could be indeterminate results, there could be variants of unknown significance. All this has to be very gently shared with the couple.
That's great. So management, after that, Archana, if you could cover up this.
माझ्याच ईमेलवर जुईनी तिथे ओपन केलं आणि मी इथे ओपन केलं तर काही बिघडत नाही ना ग?
Okay, sir, basically I think the patient should be divided into the 6 groups, as madam has said, Manjeet madam already said. The patients who have got the potential of recovery, or they would have a outcome which is nearly normal to normal life, so they can be offered the termination accordingly. Most of the patients who are having aneuploidies which are at par with life, which can go along, don't require a cesarean section. So they can be given that the induction of labor choice anytime, and progress is a normal delivery. We have to be in a tertiary care center with a good NICU care, with a neonatologist and a pediatric surgeon around to give them the better outcome. Now, even if the thing is not compatible with the life, or you can say the third group, which may require a permanent supervision or a medical care, or such condition where the family is not wanting to undergo the termination, we should give them a proper counseling. They should be given a regular perinatal care along with local and online support groups, so that they can be counseled very well regarding the financial and the social implications which they are going ahead with. So a comprehensive approach with emotional empathy and properly planning a delivery in a proper place would help in a long run. With a neonatologist and maybe a pediatric surgeon at hand, this would be a good care advice later on.
Thank you. Now we'll have to run up a little bit.
Can I just make a small comment?
The time factor. We'll run up fast, briefly. Just a few words on pre-implantation diagnosis.
So pre-implantation is where the fertilization between egg and the sperm is done in vitro in a laboratory. And in cases of difficult failure to conceive or infertility, it could also be done if you want to test the, the pre-implantation biopsy. If you need to do it, you want to test the embryo before you transfer it. And you can do a whole lot of tests before that. So rather than, subjecting the lady to a pregnancy and termination after that.
So fetal health checkup schemes are also available. Between 11 and 14 weeks, this is what can be done. Between 18 and 20 weeks, this is the panel. And between 30 and 32 weeks, and thereafter 32 weeks and thereafter to term. Now, this is very important, which I want to quickly cover, and how to calculate the risk. So this is for all. There is Mrs. A, 35 years, Gravida 2, Para 1, Living 1, 12 weeks pregnant. Single live fetus, appropriate for gestational age. And we have to calculate her risk. What is the risk for having a fetus with Down syndrome? Ashwini. Or any?
Ashwini. Right. All right. Okay. So the concept of screening and risk evaluation goes as such. There are two risks that we are talking about: the a priori risk and the post-test or the final risk. The a priori risk is determined by your age and the gestational age of the pregnancy. These two things we cannot change. So that is the baseline where you start off with. Thereafter, whenever you do any screening test, each of these screening tests or markers are associated with likelihood ratios. Means how strongly positive or they are likely to increase your probability of having that problem. And these likelihood ratios are multiplied, and then you get a final risk or a post-test risk, which is what we are supposed to look at and base our decisions on, no matter how high the a priori age-related risk might be.
So after doing all the first trimester, dual marker, the NT scan and the history and everything is taken, the risk shown what her age would be 1 in 270, but it is worked out to be 1250. And we have to be sure before telling this to the patient, because if you miss anything else, you will think it's a low risk. But once you tell the patient that this is 95% certain, and doctor, I'm so happy that you told me this, my first child has Down syndrome. And so I was so worried. Thank you so very much. If you have missed anything, which you should be knowing in the history, the a priori risk or the likelihood ratio, this is how we will appear in front of the patient. Be very careful. So I'm going to run through this because this is here. There is an isolated ARSA in TIFA. If you know the value that it is 3.94, then this is the way you will calculate her risk. You will put the age risk and multiply by that the risk which she is at, likelihood ratio, and the answer would be different. So take a message. In the years to come, the demands for a high quality fetal medicine and therapy will steadily increase due to the growth of the three factors which are mentioned here: continuous improvement in the diagnostic and therapeutic capability, increasing perception of the fetus as a person, because till you don't look at the fetus as a person, you are not going to think like how you would be thinking taking care of a person. And increasing awareness and demands for advanced fetal medicine and therapy and solution, the developing imaging techniques and the molecular medicine will allow diagnosis and treatment which is not imagined today. With these few words, I would request Dr. Vandana Bansal to come in, and I have shot up by 10-15 minutes. She should also get those extra minutes for herself. Yeah, Vandana, please come.
Dr. Raju, thank you for the exhaustive revision of everything in fetal medicine, excellently taken through. So what I'm going to do now is start take you through some cases and we have such a good panel of experts, and we are going to work on the applied fetal medicine now as to what we have been discussing, and now how do we apply it in difficult situations. So, sir, can you?
Yes, it's all you now, Vandana.
Yeah. So, I'll share my screen. So we'll go on to some case-based management of abnormal ultrasounds, as well as some lab reports that we have. So Dr. Pooja is not there. So I think again, everybody will have to chip in somewhere or the other. So we are first going to go on not to a normal increase NT, a person with an increased NT which is recurrent. So I think we can start with Meenu. You do a lot of infertility work, and this patient, she's a doctor herself, has come to you, gravida 3 para 1, living one live child, and the NT that has been given by Dr. Pooja Lodha is NT of more than 95th centile. What comes to your mind? What would you want to screen or do a diagnostic or an NIPT in this?
I think I would screen her for biochemical test also. We'll do the double marker and take a combined screening, combined risk, and then go ahead. There are some publications where they say if the NT is more than 95th percentile, you can straight go for an invasive testing. But I think I would go for a combined screening and then go ahead for and then decide whether to where do we stand.
Ashwini, you want to add on to something?
Ma'am, the ductus venosus and the heart on the TVS, I'm assuming they are normal.
Oh.
Okay, so no, so I would, if the heart and the ductus venosus are fine, I would also wait for the dual marker with this NT and take a look at the combined result.
Okay, so both the obstetrician and fetal medicine are with us.
Yeah, and together.
So no, they are all difficult cases. So I'll have lot of controversies, and I enjoy that controversy. So we have this NT which was high, and the dual marker, the first trimester screen has come as 1:1085. So it's a low risk screen. Are you happy? You want anything more to be done, or you're okay with this?
I am not totally happy because there is one ultrasound report which is showing increased NT. So I would like to follow up this case on another ultrasound reports.
Okay, so like how you are worried, all the obstetricians are worried, and the patient herself was a doctor. So she went around and got an integrated test done. We've already spoken, Dr. Raju, that integrated has got a better sensitivity. So she went around and got an integrated test, and it came as 1:513. So
I
now
would also counsel this patient for NIPS. Yeah, sorry.
Yeah, NIPS. Okay. Ashwini, you want to add on something?
I know. I probably wouldn't have done the integrated with an increased NT. I would have called her at 16 weeks for sonography to take a look at the heart, and based my decisions on the findings of that sonography. And if the sonography is, of course, abnormal, the pregnancy takes that course. If sonography is again completely normal, I would still want an either first choice invasive or second choice if the family is completely reluctant, only then an IPS.
So for this patient, she came to us after this intermediate risk. And as what Ashwini said, that we would want to look at the structure of the baby completely and also look at the heart. Even at 17 and 16 weeks, you can actually do look at the heart and see whether there is any abnormality. So now we are with a patient who has an increased NT, a normal first trimester screen, an intermediate integrated, a good anomaly and echo. So as you said, you would want to do an amniocentesis.
Yes.
I would also want to do an amniocentesis. And it came as fish normal. And the karyotype, because she came at 17 weeks, the report came to us at 19.6 weeks. We all obstetricians are on the edge of our what to do. And we reassured, okay, fish is normal. but then there was a sex chromosomal inversion at 19.6 weeks. So, Dr. Meenu, what would you want to do?
I think we should do fish and microarray. I mean, microarray we should do so that because this is a little, I would counsel the patient, but if they say no, we cannot afford it, then of course we can go for fish.
Dr. Manjeet, you want to chip in?
I will
Yeah, because she is one day prior to the legal cutoff for MTP. There's hardly anything that we can do now. Karyotype can give you an indication of this inversion, but as Madam has rightly mentioned, a microarray will tell you if there are any loss of any small region or a small segment of the chromosome and how many genes and what is the size of that region. Right now, there's nothing we can do, but microarray is definitely the preferred test.
So this was done about 3 years back, and we had to do a parental karyotype to understand what the inversion was. But as everybody is worried, the obstetrician went around and got an MTP done because this was the last day. She had an NT which was high and some inversion they are seeing. So MTP was done. She's a doctor.
I would also store the sample, her genetic material, for the next pregnancy.
So we are doing now the next pregnancy. Now we went all wrong that she started off with an increased NT. Probably there only we should have probably done an invasive testing or maybe a little early and did a microarray. Now next pregnancy she's come back to us and again an increased NT above the 99 centile. First time she had a karyotype which showed inversion, no microarray, no DNA safe because that was 3 years back. And now she's again come with an increase NT 99 centile. Dr. Meenu, now you want to do a microarray?
How many weeks is she now, you said?
She's now 12 weeks, first trimester. She's come at right time now to us because
I
we
think we
counsel
will do a CVS and a microarray for her, right?
Yes. So now for this next pregnancy, we are not going to look at integrated and dual marker screening. We are going to do a CVS on this patient. In the meantime, we got her parents tested and the father had a sex chromosomal inversion, which probably is being presented on to the next child. So this may be
Just one comment. If the father was normal with the same inversion, so maybe the child also would have been normal.
Child was normal. That's what I'm trying to say, that went all wrong. Could have been a normal baby last time. We didn't have time for karyotype and the obstetrician was all hypersensitive to it. So now we knew, we are already educated that the father had this inversion, which is usually a Y inversion. And so that previous child was probably normal. But here we got a microarray done. So as Dr. Meenu said that we should have done a microarray in the first place. And we came up with this disease of Charcot-Marie tooth disease. So we had to go into literature to look at what it can cause. So Dr. Manjeet, can you enlighten us on what is Charcot-Marie tooth disease, which comes up on these microarrays and whether it's associated with NT increased or not?
Yeah, so CMT is actually a very heterogeneous group of peripheral neuropathies, and the inheritance could be autosomal dominant, autosomal recessive, X-linked, and in fact, to add to the complexity, there are more than 30 loci genes which have been identified. Now, once we know that there is a deletion, which you're seeing it on this microarray, you look out for the causative genes in that. The most common gene seen in Charcot-Marie tooth is the PMP22 gene. And it's a 40 kb gene that consists of 6 exons, where all the coding information is stored. And this provides the instructions for making the proteins, which are required for normal functioning. So we can do a targeted testing and we can understand exactly what is wrong and we can accordingly prognosticate.
So Manjeet, are we not worried about all these reports which come up for something else that we were looking at? We started off with an increased NT looking at Downs and cardiac and other syndromes, and we come up with these disorders which are degenerating disease of adulthood. So a baby of 12 weeks, we are prognosticating about their adult life. So Dr. Archana, can you chip in to tell us if you have a patient who comes with you with this report, will you terminate for an adult onset disorder now? Dr. Archana. I'm just
Ashwini wants to say. Ashwini wants to say something.
Anyone can add on because Pooja's questions I'm taking it up.
Let Pikesha sir.
Sir, Pikesha sir.
I think counseling here, you cannot tell the patient whether to terminate or not to terminate. You have to counsel the couple. But let us take Pikesha sir's opinion on this.
Sir?
I think I don't have much of an idea about CMT. So I think we'll have to rely on Manjit to really go for it.
So they finally actually went to pediatricians, to neurologists, and everybody said it's a big disorder, that the degeneration is very bad later on, and so finally they terminated. So an increased NT first time was a problem, and second time a microarray with such reports. So what literature says is that increased NT, especially if it is more than 3.5, should be evaluated by invasive testing by microarray and not by only karyotype.
Agreed.
Yeah. Ma'am, recurrent increased NT, Noonan also. So exome probably, if the family can afford, can be borne in mind.
Yes.
Also, as far as this, as you mentioned about the chance finding, no? So typically we tell the obstetricians that if you are doing a chorionic villus sampling for something like a beta thal or a single gene disorder, it also helps to do a karyotype. Sometimes we pick up balanced translocation or an unbalanced translocation also. So if you're doing it for a monogenic disease, and since you are sampling and doing an procedure, it helps in doing karyotype also.
So I go on to a question to Dr. Archana or Dr. Meenu, anyone can take it. When you do a screening for first trimester, do we repeat another quadruple in the second trimester, independent of each other?
We don't, no.
No.
That's a bigger filter. So whatever is filtered, you're again filtering the same thing.
No.
So no. That's a big
no two combined tests which are independent of each other.
True.
Because what is going to happen is the number of high false positive screenings will increase. And so they may have one report which is normal and one abnormal. What we need to do is what we call as an integrated test. So just to go through an integrated screening, you do a first trimester combine it with a quadruple test, and you get a final integrated risk. And this has a very high detection of 95%. The problem with this test is that the final report will come after the second trimester. And so 2 samples will be required. And what is more better is a sequential stepwise screening where we do a first trimester screening. If it comes high risk, we will go on with an invasive test or an NIPT. And if it is low risk, then we will combine it with the integrated quadruple and get a risk. So we are reducing the number of procedures and getting a person to benefit from an early diagnosis in high-risk cases, and the low-risk cases are integrated with a quadruple report. So this is a concept which is good, and maybe you can use wherever you think the screening is has to be improved. So I think Dr. Archana is not there.
But in integrated, we get the result only after second trimester screening. We don't get the result in first trimester. So patient has to actually wait until then, not knowing what has happened in the in your first trimester screening. So.
But what this stepwise sequential, you will look at the first trimester. If it is high risk, you do a CVS.
Correct.
And the rest you will go on to do a low risk once. And there is also this contingent where if it is very high risk, you'll do a CVS. If it is very low risk, 1 in 1,000, you will not do anything. And these intermediate risk ones, you will do the second integrated test, and then depending on that high risk. So these are all practically can be done, but how much practical we can do it in India is what we need to look at. So we go on to our next case. Screening in twins. Do we not do? Meenu.
Of course, we will do the screening in twins.
What screening do we do for twins? And does chorionicity matter?
Yeah, chorionicity will matter, of course. I would probably again do a double marker along with the anti-scan. And very important, another thing is, suppose it is a donor egg patient with a twin pregnancy, IVF conceived patient, we must mention the age of the donor and not the age of the mother. So otherwise you will get a high, patient will unnecessarily fall in a high risk group.
So Ashwini, does the detection for twins is as good as singleton, or is it better in singleton than twins?
Slightly better in singleton than twins, but as far as dichorionic, diamniotic are concerned, they're almost as par with singletons. Only in monochorionics, slight problem because the increased NT.
Actually, go on.
Okay, all right. Because in monochorionics, the slightly increased NT can also be because of other reasons related to monochorionic placenta. That's why we are a little lower on the aneuploidy detection. So in monochorionics also we do the same, but use the average NT of the fetuses.
So in case the patient misses the first trimester, then Ashwini, do you ask for a quadruple test for twins?
Absolutely not. No.
Minu?
Sorry, I didn't get your question.
Do you do a quadruple test if they've missed the first trimester? Twins.
In a twin pregnancy. Well, if Ashwini is saying no, then I will also say no.
Good. So first trimester screening, we need to look at what is the dating that for any singleton or twins, and if it is IVF, we use the embryo transfer date. Chorionicity is extremely important, because if it is DCDA, then you will get 2 risks, and if it is MCDA, you will get 1 risk. And also you need to do a good labeling of the twins, because whatever you are going to screen now, you might get an abnormal report, and then you'll need to work on that. So MCDA, you get a risk per pregnancy. So it's a mix of the NTs of both, and then they combine and give you a screening risk. And if it is a DCDA, you get 2 different reports. And so you can know from the increased NT which one is the fetus that is abnormal. And as everybody was with me to say that quadruple is not recommended. So if they have missed, then we do a good anomaly scan with a good soft markers and look at everything else. For triplets, again, no other test except a good first trimester ultrasound. And if there's been a reduction, again, no other biochemical test. And if there's a vanishing twin with a fetal pole, again, no biochemical screening. Ashwini, correct?
NIPS has no value for a multiple pregnancy. NIPS should be done only in a singleton pregnancy.
And maybe whenever there's a vanishing twin also or a reduction, NIPS is not going to work. There are some labs which are doing NIPS for twins.
Yes, ma'am.
I think will work for monochorionic, may not work for DCDA because 2 different genetic materials. So again, a very difficult case. She's a 38 years gravida to para 1. Her age itself is on the higher side. It's a DCDA. You can see the twin peak sign and the 2 fetuses. The NTs, nasal bone ductus, all looked all right. So was sent for a first trimester screening. Now, if you look at the report, you will see that you have 2 risks. So because it's a DCDA, one risk is 1 in 255 and the other risk is 1 in 369. So who will answer? Archana is not there now, no? She's left.
No, madam, there is one emergency, so I'll have to leave, but I just joined in, yes.
Even I have to leave in 5 minutes.
So maybe this maybe Minu, you take it. Next one, Archana can take it. So you have these 2 intermediate risk values. What will you do? We were saying NIPT is not so good.
She is 38 years old and it is a precious pregnancy for her. Actually, amnio would be a good option from each sac, but we have to counsel the patient because there will be a small risk of her losing both of them and then may not be conceiving again. So that, keeping that in mind, I think we should counsel the patient for amnio. I mean, if somebody has something else in mind, we can discuss.
I think, Dr. Minu, this is a good option because of the high risk and her age also. So that can be offered, and mostly with a minimum risk with amniocentesis, she should be taken forward with that.
I also agree that we need to do an invasive test because you cannot leave this kind of a report and have a baby born with Down syndrome.
But having said that, I've had patients of this age with high risk. So, and saying that we do not want to do amnio, whatever may be the result. So we have to counsel the patient before sending the biochemical markers that this is just a statistical data, and then we may have to do further testing. If they do not want any further testing, then there is no actually point of wasting their money in doing their marker tests.
Ashwini, will you do an amnio or you'll do a CVS? She's still in the time period for a CVS.
The decision will be based on a couple of factors. One is how were the placentas placed. So basically accessibility of the placenta for the CVS. If they are completely anterior and posterior in a dichorionic diamniotic, I would still be okay to do a CVS for twins. But if there is any doubt that they are close by, or there is even a slight possibility that there could be contamination during CVS, I would rather be more comfortable doing an amnio for twins, where the labeling has been done very meticulously. Preferably the person who is scanning all throughout only should be the one who is doing the invasive, and labeling has been done. We know mentally which one we are sampling, and then amnio. Until and unless bang anterior and posterior placenta, only then. Otherwise, preferably amnio for twins.
Okay, so this patient had a posterior and anterior placenta with the twin peak sign, and we were comfortable doing a CVS for both the babies. The advantage of CVS is that you report early, so your reduction is also early.
True. True.
And excellently said that the same person who does the screening has to do the invasive and also label them correctly. And so, as we thought, one report was normal and the twin B had trisomy 21. They had a normal NT, all markers were normal, only an intermediate risk, and this trisomy 21 came up, which is positive. So now, Ashwini, what are the risks of reducing with the normal looking two babies? The NTs have become all right. There's nothing that we are seeing.
True. So a very tricky situation. Again, the importance of the person who is scanning, who is doing the invasive, is the person who should be taking up the selective fetal reduction in this case, because the labeling, the identification of each of the fetuses has been done. If they have discordant sex, that's one way of knowing which one we are reducing. The labs can, of course, share with us that data. So during reduction, that can help us. If they are concordant in sex also, then God help us. We have to be very, very careful. We can take a look at the placenta and the cord insertions as the labeling points. And then, of course, the person who has sampled, and rather also the person who has packed the samples and labeled them, that is also very, very important. So if we know that the anterior placenta fetus was the one whose result has come abnormal, then we reduce. But scrupulous record keeping and scrupulous attention to labeling at all times, and preferably one person doing everything.
Yes, you cannot have two people, one doing the procedure and somebody else doing the reduction. You can get into a big mix-up. So we go on to our next case. Dr. Archana, we are with you now.
Yes.
Aptly nasal bone. So we have this patient who had an isolated aptly nasal bone. So you can see whether these images are correct or whether you want to think that the images may be changed. She's 17.4 weeks. So what test will you ask for? Are you going to now ask for a quadruple or go by your first trimester screen or an NIPT?
No, madam, she is into the ideal time frame of a quadruple test. So I would go with a quadruple test. As isolated absent nasal bone, we discussed very well in the previous slide. It may be a euploid fetus also, but with the quadruple screening, and then we go stepwise only. If there is a risk, then we go for the NIPT and then later on amniocentesis. This will be the plan of management. But at first, and the close monitoring in this case, because there can be other syndromes which can be associated with it. But isolated absent nasal bone won't require much of the tests.
Ashwini.
Yes, ma'am. What was her NT and dual, ma'am?
We don't have any report.
We don't have anything. Okay. Right. Okay. So no, I would not be comfortable leaving an absent nasal bone with a quadruple, because absent nasal bone is a soft marker with a very high positive likelihood ratio for Downs. If the entire fetus is absolutely normal, only then I would even suggest NIPS, but my first preference would be an invasive. NIPS only if they are extremely reluctant for any reason to do an invasive, only then. And also we are 17 weeks. So little, if at all they delay in decision making, we could run out of time as well. So my preference would be invasive.
So Pikesh,
okay, ma'am, but as an obstetrician, probably as I would like to go that if the whole fetus is looking normal, probably I'll stick to quadruple test and then go stepwise. But I'll take your word that we'll take an opinion of a fetal medicine expert at this point of time to get a proper scan.
Pikesh, sir, you'll have to add on. What is your opinion on absent nasal bone isolated? Sir, you'll have to unmute yourself. Sir, unmute yourself.
Like what Ashwini said, that if all rest of the parts are normal, there is no anomaly seen, you straight away go for invasive, because NIPS can pick up only the aneuploidy and you will not be able to pick up the rest of the things. So I think you go straight away for diagnostic test. Oh yeah.
So yes, absent nasal bone may be absent in lot of Asian population, but it has a very high likelihood ratio. So I think the fetal medicine people will not leave this and go on for a quadruple test. So this patient with only an isolated absent nasal bone had a trisomy 21. So Dr. Manjeet, for absent nasal bone, are there any other genetic abnormalities, or we are happy with only doing a karyotype? Here, do we do a microarray?
So, as per literature, what has been reported is a very high percentage of people with a Down syndrome, that is a trisomy 21. Besides that, we have seen trisomy 18s also, and there have been some reports on microdeletions in odd chromosomes, like in chromosome 7 or something like that, So, and as you also mentioned, the fetus could be euploid with an absent nasal bone. So trisomy 13, 18, 21 are the highest chances, and you may get some microdeletions or even sometimes in a Turner syndrome, it's been reported.
So there was a discussion on an isolated absent nasal bone. So Ashwini, when we see this absent nasal bone, you would also look at the heart, and here you see can you describe it?
Yes. Okay. So this is a 4-chamber view of the heart. What we are not seeing here is the intact crux. So the diagnosis would be balanced atrioventricular septal defect, one of the cardiac congenital heart defects with a very high association again with Down syndrome. So if we see this and an absent nasal bone, it's straight away an amnio.
Yes, so maybe we would have done an NIPT in the first case.
But this one is absolute amnio.
And termination. So, Dr. Manjeet, we have this non-disjunction trisomy 21. How will you counsel the patient for recurrence in the next pregnancy? And what type of method of your screen will be done in the next pregnancy?
So a free trisomy 21, as we call it, having 3 individual copies of the chromosome 21, as against, sometimes you get what is known as a translocation kind of a trisomy 21. So in this karyotype which you exhibited, it was a free trisomy 21. So the recurrence risk is the same as that of the background population risk, So it could be as per her age and other factors, which is less than 5%. So there is no increased recurrence risk in the case of a free trisomy 21. If it is a translocation type and one of the parents are a carrier, there the situation is totally different. So for the next pregnancy, again, we screen it as we do it for the normal routine pregnancies. NIPT will definitely be required to be offered to them.
Yeah.
And no invasive unless it's indicated.
So we go on to the next case. This is a case with a lab report showing some abnormality. So we have a quadruple report. She's a patient who is 34, 35 years, IVF conception, 3 abortions. She's chronic hypertensive, and she's got a quadruple test done. So, Dr. Meenu, can we look at if we have, so the down screening is low risk, but there is an increased risk on neural tube defect. So what are the implications? How will you counsel this patient? Dr. Meenu. Dr. Archana can chip in. Both are not there. Anyone? Archana.
She is 34 years, madam, chronic hypertensive and 18 weeks. So here the invasive test would be a good option for her.
Her risk is for neural tube defect, not the risk for Down syndrome.
Down syndrome. Okay. And a proper skeletal evaluation of the like level 2 ultrasound would be a good answer for this patient.
So basically, we are looking at the structure of the baby to look for neural tube defects, and also they may also be associated with growth restriction. These which have a quadruple report positive are ones which have an increased AFP, and so we anterior abdominal wall defect, neural tube defect, anencephaly. But if nothing, then it could be a growth restriction, which may be the reason for the increased AFP that we have. So here, this patient had a discrepancy of 2 weeks. Uterine arteries were very high, umbilicals were normal, they were followed up. Basically, I am not going to go into the management of IUGR and Doppler, but what I would want you to understand is from this learning is that increased risk of neural tube defect on a quadruple test, do a good anatomy scan for spine, anterior abdominal wall and Doppler, and then follow them up for IUGR. They don't need an amniocentesis. So maybe this I put in because we wanted lots of these patients come with an increased AFP and come for an amniocentesis. So they actually don't need an amniocentesis. So we go on to next case of a surgically corrected. Jui has been quiet for a long time. So I'm going to now get on to a case where I want the pediatric surgeon with me. So I think Ashwini, you can start with, this is a 35-year, 31 weeks of gestation with polyhydramnios. So what is the ultrasound findings that you have?
Right. Okay. So the transverse abdominal sections are showing the double bubble sign. One being the distended stomach and the other being the first part of the duodenum. So with polyhydramnios, the first diagnosis would be a possibility of a duodenal atresia.
Yeah. So do we get these duodenal atresias picked up very early, first trimester or 18 weeks?
No. No. So first trimester, absolutely not. The second trimester also unlikely. So they would present mainly in the third trimester. By around 24-25 weeks is the earliest suspicion that I have seen.
So Archana, you get a patient at 31 weeks, they said anomaly was completely normal, and now you're saying that there is a duodenal atresia with polyhydramnios. How will you manage her? Archana, Meenu are not there with us any longer. They've become quite tired. So
Right.
You go on.
Yes. All right. Okay. So yes, amniocentesis I will offer, but the uptake is very, very poor. From my end, I will encourage the family to do the amniocentesis, because if it is at least trisomy 21 proven, a cesarean section can at least be avoided for fetal indications. I mean, if anyways it has to be done for maternal, if there's no choice. But yes, I would encourage amniocentesis at this stage also.
So even I would also ask for an amniocentesis even at 31 weeks of gestation, maybe therapeutic also, as well as looking at the diagnosis, because almost 40% are associated with Down syndrome. So this patient amnio was done and came out as trisomy 21 again. So now when and where do we want to deliver this baby? Ashwini, go on.
Okay, right.
Professor can add on.
Depends on how bad her polyhydramnios is. So we can do the amnio reduction if she is breathless or if the cervical length is rapidly dropping, and hopefully push her along at least till 34 weeks. The where to deliver part would be preferably in a tertiary care institute where they have the pediatric surgery help on hand.
Dr. Archana, we were talking about the case of duodenal atresia.
Yes, yes,
madam. Polyhydramnios. What precautions are you going to take so that she reaches more near term?
She'll be advised about the polyhydramnios, that anytime leaking can happen. So strenuous activity she'll be avoiding, and she'll be coming for the regular checkups, maybe a little more frequent checkups than the other antenatal cases. And here, as madam was saying very well, that we have to plan a delivery at a tertiary care center because of the neonatal ICU setup is there, because this baby will require immediate neonatal care. If not in the first 24 hours, because liver reserves and everything is there. But with polyhydramnios, again, there is a high chances of having a cord prolapse again. So this patient needs to be at a tertiary care center where immediate delivery by a cesarean section if required, the facilities available. And in the antenatal phase only, anytime whenever the patient is coming with polyhydramnios, we have to be well prepared with the risk of having an early delivery. So giving a shot of steroid will be a good answer in this patient. And as far as we can pull on, we will deliver her as a routine obstetric patient only.
So Julie, do you want a preterm baby or you want a term baby for operation? Dr. Jui?
A term baby is always preferable for surgery. A preterm baby is also okay in the case of duodenal atresia. It is not going to make much of a difference surgery wise. The questions that are here are, what are the postnatal initial investigations? So initially, when antenatally diagnosed as double bubble and postnatally we will get an X-ray done after the neonatologist has stabilized the patient, we will first put in a Riles tube before taking an X-ray. Once the Riles tube is put, we'll do an X-ray and see whether there are two bubbles, whether there is some gas shadow beyond that, because duodenal atresia sometimes is associated with malrotation, and that is the only time where we would have to go in for early, immediate, urgent surgery. Otherwise, anyway, so duodenal atresia is not an emergency. We will wait for cardiac evaluation, 2D echo. If it is a Down's child, cardiac anomalies are more common. We would look at urogenital system. We would do a sonographic KUB to look at the kidneys, whether they are normal, whether there are any abnormalities, because these patients are allowed, they sometimes have those genitourinary problems. Once everything is settled down in a couple of days, we can plan for surgery. Sometimes it happens that when we take an X-ray immediately after birth, the air, you don't see a double bubble. So then you have to push in around 20 cc of air to look at whether it is going distally or not. So that are the initial investigations. So basically, we have to rule out any other anomalies. Does prenatal diagnosis help in improving outcome? Definitely. I would say that if you fail to prepare, then you prepare to fail. There are many things that we need to prepare. We need to prepare the NICU. We need to prepare the parents, because it is certainly going to be an additional cost for them, and they are not going to be taking the baby home in the next 2-3 days. That is what they have to realize. Also, when there is a duodenal atresia, there is a chance of him being a Downs. That also will have to be explained. And if he is a Downs, there are a lot of problems associated with that. So we need to give the parents some time, counsel a lot for them to get used to the idea of having a Down baby as well as duodenal atresia and all of these things. So yes, prenatal diagnosis does help. Everybody is a little better prepared. The delivery takes place at a tertiary center. We are not rushing around. The baby's health is not compromised.
And most important is that if we know it antenatally, the postnatal, that vomitings are more common, so aspirate, and then death on bed is the most hazardous thing any obstetrician would, because we cannot sit by side and we have to leave it on staff sometimes, and sometimes it may have aspiration, asphyxia, and so prenatal diagnosis is always good for everybody.
Absolutely.
So they have got good results, duodenal atresia for lifelong and for survival.
Definitely. I think duodenal atresia, once they get through the first 10 days of life, they are set for life. They don't, because it's a diamond anastomosis, they don't have any secondary stenosis, secondary stricture or anything. They don't have any problems. Only thing is with duodenal atresia with Down, it takes a longer time for us to feed the child. It takes a longer time for the child to come to full feeds. So that needs to be told to the parents.
Okay, so we go on to our next case of a resolving abnormality. So I think again Ashwini will have to start with. She is a patient at 19 plus 6 weeks. We have 1 day available for termination if required. So here
Right.
There was a mediastinal shift. There's a large echogenic lung mass which is occupying almost the whole of the
left
lung. So, Dr. Meenu, Dr. Archana, first you start off. Will you want to continue or terminate with such a huge lung mass and a mediastinal shift? We have got time of 1 day with us. This is a CPAM that we are seeing. So it's a congenital pulmonary airway malformation.
She's just 19 weeks, ma'am. 19 weeks, no?
Yes.
6 days.
6 days. So I think we can, since it's a resolving type of abnormality, so we can take help of a neonatologist, as I may not have a luxury to have Jui ma'am all the time around, but I can always have Ashwini ma'am type of a help with me. So it will be a group counseling, and the patient itself has to take the call that whether they are ready to bear the brunt of the finance and the other things which are associated to proper counseling, and then we have to take a group decision whether she wants to go for a termination or she can take that call to continue the close monitoring and later on the surgery and other things.
Definitely.
Can I say something?
Yes,
CPAM usually will go on increasing in size, will plateau, and then probably will stabilize. Now the issue is, if the child is born with a CPAM, it is an easy thing to take care of. The only thing is that whether the child will go into hydrops or not. So I would strongly advise not to terminate, because if he goes into hydrop, that is the child, that is the baby's fate, and that you cannot do anything about. But if he does not, and if he survives, then CPAM after post surgery has a very good prognosis.
I am also strongly of the opinion that CPAMs resolve after 26 weeks of gestation. So terminating for the reason of CPAM may not be a good idea. But yes, we need to have the pediatric surgeon, the NICU, obstetrician, fetal medicine, all coming together to decide. So Dr. Ashwini, how do you prognosticate these CPAMs? Is there a ratio that you look at?
Yes. So whenever we diagnose a CPAM, the follow-up depends on the CVR, that is the CPAM volume ratio. So online on the perinatology website, we can put in the length, breadth, and width of the height of the CPAM lesion and divided by the head circumference, and we get the ratio. If it is less than 1.6, it's considered generally good prognosis. Only thing that they are not considering is the cyst size, basically. Only if any lesion has a dominant cyst, then it could be a little different, even though CVR is a good prognosis. But overall, if CVR is less than 1.6, absolutely no need for termination, no need even for invasive investigations. So very rarely associated with aneuploid. I mean, not associated, especially if you have a normal NT dual. So basically, they just need to come back and keep seeing you every, say, 2 or 3 weeks, depending on the size.
So Dr. Manjeet, as Ashwini said, we don't need to do any invasive. So no chromosomal or genetic abnormalities with CPAM?
Yeah, so they actually occur sporadically. They are not known to be inherited. And like previously, we used to call them cystic adenomatoid malformations. So there is some gene that was associated. They say that FABP7 gene, but it was described for brain and breast development, and not for these lung cysts. And otherwise, the recurrence risk is not high. It is not inherited. It doesn't recur. And it's just monitoring and managing, just ensure that it doesn't proceed to high drops.
So this significantly increased till this was 23 weeks, the CVR increased. But finally, this is the same patient. Can you imagine that there is mediastinal shift has come back to normal, the lungs have come back to complete normal, and she was taken till 40 weeks. She had COVID. She was delivered in a COVID ward, and then the baby went home. No lesion at all seen. So complete resolution. So CPAM is something which everybody needs to understand that it can resolve. But as what Ashwini said, that if there is a dominant cyst, this is another patient who was 23 weeks with a dominant cyst. So here the implication is different because there can be a chance of high drops. So I think Jui, you had managed this patient. So if you have a CPAM with a large lesion which went on from 23 weeks, 29 weeks, the cyst went on 33 weeks. We were monitoring the high drops. We were thinking whether we put in a shunt or not. Polyhydramnios built in. What time do you want the baby out? You want a term baby or a preterm baby?
So I would want the baby out earliest. Earliest that you would have lung maturity, that if you would get the more closer to term, that dominant cyst is just going to increase. And at delivery, it is going to increase further. So we are looking at a perinatal drastic increase in respiratory distress and urgent surgery. So I would rather have a little preterm baby rather than have that cyst increase and compromise everything. Because already as a polyhydramnios, we are looking at an imminent problem. So even if I have a little preterm baby, it is easier to manage that.
So how do you decide whether you need to operate on them or not operate on them? I think all CPAMs don't get operated. What decides?
No. So immediately after birth, we look at the child for 4 days and see whether the child is having significant respiratory distress or not. If the child is not having respiratory distress, then we would, and there is no dominant cyst. If there are multiple solids, microcystic or macrocystic, but there are not a large cyst, then we would, if the child is fine in 3-4 days on room air, we would probably discharge him we would give him a big sort of literature saying that what are the red flag signs, because they are prone to infections and all. But I would definitely keep him on follow-up, and if it is there at 3 months or so, I would definitely operate and get it out. Because see, if you leave us, even if CPAM resolves completely, I would get a CT at 3 months of age and make sure that nothing is there. Because these CPAMs, even if a small focus remains, they are prone to malignancies like rhabdomyosarcoma or pulmonary blastoma in infancy, that is still 2 years of age. And they give rise to different tumors a little older in age. So yes, if it is easy for me to go and operate, I would go and get rid of it. Not in an early neonatal period, in maybe around 3-4 months or so.
Okay. So I think this is the last case, a late onset abnormality. Meenu is not there, so I think Archana, you'll have to work with me. She's a 28 years non-consanguineous. First child died. We don't know what caused it. She had a good dual marker, low risk, anomaly good, and then at 26 weeks, all long bones were short. So, how will you counsel these parents? What are you going to tell them? Everything was okay at 20 weeks, and now you've got a baby which has got query a skeletal.
This is a skeletal abnormalities is associated with this. So this is a very important part of counseling because we have to undergo certain investigations, more also proper skeletal analysis of this baby along with the spine defect. So each and every skeletal aspects has to be properly diagnosed by the method of scan. If required, MRI, fetal MRI can also be offered to this patient. And the relative and the mother, the parents especially have to be told about the skeletal deformities and implications once the baby comes out also. Because multiple fractures, respiratory problems, and probably a cesarean delivery also, because and a little preterm delivery probably. So these are the few things which needed to be told to the patient. And once the baby is out, the baby needs to be investigated thoroughly more about it. And again here the heart, the cardiac scan will be important, and also the urogenital system scan would be very important.
So when we do an anomaly scan, it's always important to tell the patient that there may be some disorders which may come up later on. So not that anomaly scan good is a perfect baby. We need to counsel. Ashwini,
yes, ma'am.
Don't look very thick to me.
Yes, that's what.
You want to...
So, first I want to know what happened to that previous kid. Any records of that sudden neonatal death? That could be a pointer. And second, I mean, two things I want to know. Are the parents also short? I mean, not that they're good
both,
height.
They're
okay. And just as a, by the way, to rule out, uterine artery and Dopplers are all well. Okay, so we have essentially...
Look at the female
exactly, yeah, that's what. So we essentially have a structurally normal baby, normal Dopplers. So we are not looking at IUGR with a severe lag in the long bones. Along with that, the long bones are looking very thickened. The ventricle was also slightly 10 or 11 mm. The skeletal dysplasias could be one of the investigations. The liver size is okay, ma'am, on the scan by any chance?
Yeah, the chest was very small, so the abdomen was protuberant.
Brilliant.
The liver size was slightly enlarged. Yes.
Okay, so basically all the mucopolysaccharidosis and things like that could also look like this at this point of time. We need to tell the parents about all these possibilities. If they are willing, again, invasive testing even at this stage, I would offer. But nothing much in terms of interventions. We just have to monitor them and deliver them appropriately.
Dr. Manjeet, is there a skeletal panel that we have which we can offer them at this moment of time, or what can be done? See, it could be skeletal, it could be metabolic, lot of autoimmune disorders can also cause. So what panel is available?
Yeah, so as far as the skeletal dysplasias are concerned, the most common one we know is achondroplasia. And for this, we test the FGFR3 gene. And we see quite a few cases in our practice. What needs to be noted is that the parents of the children born with achondroplasia, mostly they have a normal height and stature. Besides that, there are several other genes, and depending on the gene, we can decide the inheritance pattern, which could be autosomal dominant, autosomal recessive, or even X-linked. And rightly mentioned, there is an NGS panel which has been developed by certain laboratories, which tests for all these genes in just one test assay. So we can rule out several genes that are known to be causative of the condition with just one test assay.
So Manjeet, will you want to do it now, or when the baby comes out, you will be more happier with the testing?
So actually nothing's going to change. So except, the management and the prognostication. And we will be able to do it even once a baby is born. If they are sure of continuing with the pregnancy, And then the reason for doing it will be more for prognostication and for deciding the inheritance pattern and for planning future pregnancies.
So although we knew this baby is going to be very, very bad, but cesarean had to be done for breech with previous cesarean section with IUGR. And the patient understood it very well that there is nothing that we are going to gain from, and there was no method of terminating. She was already 31, 32 weeks. And this is how the baby came out. So all this was not what we were looking at when we started skeletal dysplasia. So you could see a dysmorphic face. There was significant gum hypertrophy, low set tears, upturned nose. So that's why I was asking that these things may not be picked up on the ultrasound, and we would more come to know about it once the baby is born. And so this infantogram also is showing thick stippled bones. And so the baby died after 6 hours of life, but we could take blood, skin, muscle biopsies for genetic evaluation. So the moral of the story is, yes, every skeletal has to be evaluated. That this finally came out to be mucolipidosis type 2. So what is the recurrence, Dr. Manjeet, for these patients now that we have evaluated this child? Previous, we don't know what happened and what we will do for the next pregnancy.
Yeah, so this is caused by the gene GNP-TAP gene, and as it's already mentioned, it is inherited in autosomal recessive fashion. So both the parents would definitely be carrier for one mutation, which may be the same mutation, which may be a different mutation in that particular gene. So we have to do the parents testing before planning the next pregnancy. We have to understand which is the mutation each of them are carrying. And then for the next pregnancy, we can do a targeted testing to rule out those two mutations. But for the parents, we'll have to do a global kind of a testing like exome or which tells several mutations, which looks at the entire gene and any kind of variations that we see in the gene. So an exome in the parents will give an indication of what is wrong, I mean, what they are a carrier of, and then a targeted testing for the next pregnancy will tell us what to look out for.
Manjeet, can't we just do a target testing in both the parents? We already know the gene in this baby.
So we have to do a full gene sequencing of that particular gene.
Okay.
That will also help because there are many variations and many known and reported mutations in all the genes.
So we'll do a CVS at 12 weeks in all. Just a last case. This patient was an air hostess. Ashwini, will you take first baby, first fetus had this binders like faces, not evaluated and terminated. How will you report this abnormalities? What do you call this disorder like?
So basically, binder facies is a phenotypic expression. There is no underlying particular gene responsible for the facies. This facies is characterized by a marked hypoplasia of the mid face and therefore consequently a protuberant mandible or a lower jaw. Associated conditions are many maternal conditions like autoimmune maternal conditions. If the mother is on warfarin, vitamin K deficiencies, if the mother is on phenytoin, phenytoin, all of these can cause this facies. But most of the ones that I have also seen, none of these factors have ever found. It is just an isolated binder facies. I have recommended an amnio in all of them, and all the microarrays have come normal, and the babies are also normal. So that's my story with binder facies.
Yeah, but Manjeet, you want to add on? What test will you ask for?
Yeah, so a microarray, some kind of a global testing like a microarray will definitely be indicated because we are actually fishing around. We are not too sure, we don't know what we are looking out for. And these kinds of facies have been associated with Wolff-Hirschhorn, with Down syndrome, with Appert's, with Cruzon, with several syndromes. So even achondroplasia. So some kind of a global testing will give an indication of what are the abnormalities present.
So this air hostess was a beautiful girl, and they wanted to terminate. So next pregnancy they come to us. That was the first pregnancy.
Correct.
I took those records from the radiologist then, And again, there was a similar presentation with a flat nose, mid-facial. So, Archana, what will you want to do, Archana, madam? Such kind of a disorder, the fetal medicine says I don't know, and the geneticist says I don't know. The second time, and a beautiful girl is asking, I want a beautiful child.
It's a very difficult situation, ma'am, but she has to understand what she is carrying in light of the knowledge, whatever the gene defect we can see, and it is associated with so many syndromes. So, have to give her a breaking bad news, as Dr. Raju sir had given a very good slide in the initial part of the discussion. So, because we want this beautiful lady to smile with sadness rather than to have a burden all throughout the life. So, probably, yeah, you have the picture.
Yes. So they actually decided to terminate because they thought it could be a genetic disorder also, plus the facial dysmorphism. So we had decided we'll do a autopsy, do all the tests which are available. So autopsy showed nothing else except it saying nasomaxillary dysplasia, which again doesn't help us much. We got a karyotype which was normal, and clinical exome which showed some uncertain significance. So Dr. Manjeet, help me what to do in the next
Yeah, this uncertain significance is something which is a really gray zone for all of us. But let me also tell you that it is changing by the day. There's so much of research happening at an international level in all the multiple genes that we are aware of. And yeah, so for the present status, I can say anything when you say VUS or a variant of unknown significance means there is a variation in the gene, but it has not been reported or documented to cause any clinical presentation. And there's not sufficient papers, publications on that. Having said that, within 2 months, within 3 months, we have these international sites and international databases, and they are updating information every day, by the day. So then we are gradually getting more and more learned every day, and then we come to know. So the important part for this is to be in touch with your geneticist to understand. I mean, something, even a condition which they may not be have been a test 3 months back, today there might have been a test which has been created for that condition, and a variation today which we cannot explain. 2 months down the line, there will be a very clear correlation of that genotype change with a clinical presentation. So those are the things that we as clinicians have to keep in mind. Having said that, we need to talk to the patient. We need to explain to them that there is a variation, but we are not aware of the implications of this variation.
So, Manjeet ma'am, would you like to test her parents?
So that will definitely help if the same variation is present in previous generation and they are normal, like we've seen that inversion Y in one of the previous cases. That kind of an information and that kind of a testing helps. But if these are, known to be associated with complex cortical dysplasia, brain malformations, we need to be really very sure rather than, just going based on that.
So we would not do any prenatal in this patient in the next pregnancy?
So in the, unless there is additional information by way of parents testing or by way of research work.
So they again came back to me, unfortunately, the third time. And this time we only depended on scans because till now there was nothing which is available from all the autopsies, from the karyotype, the microarray, the single gene clinical exomes, and we just followed them up by ultrasound. And we had a good nose is what I was looking at. And so we went on with this pregnancy. So VUS are some things which need to be not tested if you are not able to find out any clinical phenotype for the same thing. Like this was all CNS disorders and not related to the binder facies. And what Ashwini said that we usually don't get any reports of binders and we are always lost with what to do for them. So I would finish the panel with just showing as to when we do all these procedures, most of them are done for chromosomal aneuploidies because we do so much of screening, we pick up so much of screen positives. So in our data that I saw in 2 years, 85% were because of Down syndrome screening. And among them, if it was only biochemical, dual marker, quadruple marker, only 2% of them actually had a Down's baby. But if it was a scan plus a combined screen report, the risk of screen positive was 13%. And if it was only previous Down, it was 5. So actually, those people who come to you with Down screening positive, the chance of a screen coming as diagnostic for a chromosomal abnormality is only 6 to 7%. And I think the literature also says that. So you need to counsel the patients that these are screening tests and you need to do a diagnostic test to decide, and don't just terminate on the basis of screening test. And you need to evaluate the index case. We have done all of these cases in the past 1-2 years, where you actually want to look at the index child, evaluate, get that person to meet a geneticist, let the geneticist decide what this child has, and then so that we have a assessment for next pregnancy. So I think I'll thank the panelists who has been very cooperative for a very long panel. And I think Dr. Raju, you want to add on anything?
It was amazing, and I must compliment all the panelists, and they stood by us, and they contributed so very well. It was great learning all the way. Thank you very much.
Thank you.
Sir and ma'am, and
to the
Vandana, I
moderator.
was blessed to go through so many cases. It was so vast variety, and I think the whole fetal medicine covered so nicely. So thank you for having me here, Vandana ma'am and Raju sir, with so many small practical tips.
Thank you,
Thank
thank
you.
you, sir.
Thank you to
Thank
the
you, ma'am.
moderators.
Most
Thank you.
welcome. Most welcome.
Dr.
Now we'll hand over to Komal.
I'd like to say that it's been a very interesting panel, and Vandana, excellent collection of cases. And I think what I liked most about the panel is you brought about the importance of multidisciplinary management, particularly involving the pediatric surgeon, involving the geneticist, and interventions at an early stage and when not to do, because many a times you find patients doing nuchal scan, dual marker, quadruple marker, confused, then doing an NIPT, and then coming to ask whether you should do amnio or not. So I think those things were also brought out very well. And I must compliment Komal Chavan again for selecting a very excellent team. And thanks to Vandana and Raju once more, both the Rajus, Raju Nagarkatti as well as the original Raju, for getting this panel very nicely done. Thank you very much.
Thank you so much, Suchitra. Thank you, Suchi. Thank you very much.
Thank you, ma'am.
Thank you so much, Suchitra Pandit madam. And I think it was one of the best panel which I must have heard. It was real learning experience, and it has fetal medicine, the whole of it has been discussed so much in depth, and we really don't have any confusion now, so much clarity. I think the audience, everybody must have really had a good learning experience. And thank you so much, Dr. Vandana Bansal and Dr. Raju Sahitya. You have made the panel very lively, and all the panelists, Dr. Meenu Agarwal, Dr. Manjeet Mehta, Ashwini Rathi, Archana Divedi, Juhi Manke, you all have done a fabulous job and such a justice to the panel with a great take-home messages. I thank you all.
Thank you.
And we formally conclude the program with thanking all, especially Dr. Suchitra Pandit madam, who is so proactive and he was always selecting new topics and always guiding, actually me also in making the programs. And it is all because of the guidance of madam that we have been having all different kinds of programs what we have organized. So I thank Suchitra Pandit madam, our president of the Mumbai chapter, and Dr. Nagargatti, the secretary, with all his dynamism. He's always very supportive and always there for all the programs. And I thank Dr. P.K. Shah and Dr. Parul Kotrawala, the guest of honor for today's program. Dr. Mandakini Pradhan, speaker, you spoke fabulous, very nice topic, really clear, with Dr. Ashwini Bhalerao, madam, and Dr. Urmila Surekha, who are very own part of our ISOPAP team. I thank them. And the wonderful panel which I heard was icing on the cake. Thank you all. And I also would like to thank our sponsors for today, the Integrace Pharma, for giving us this platform and also supporting us for 2 more webinars from the ISOPAP Mumbai chapter. So thank you very much, Integrace Pharma and the team, TOG, Science Integra, all of you, Shrimon, Subbu, Session. They are doing fabulous job coordinating with everybody. So thank you all. And till we meet again for the next webinar, take care and stay safe. Thank you.
And Komal, I'd like to invite members for the Mumbai ISOPAP chapter to do please get in touch with Komal and get membership.
Yes. Our chapter is growing and many people are coming forward for membership, and I do appeal everybody to become member. It is a very simple thing and we all will work together. That is the beauty of our Mumbai chapter.
Thank you, Komal, on behalf of all the panelists and for having us over here for such a wonderful panel. And thank you, our moderators, Dr. Vandana Bansal, amazing cases, and Dr. Raju Sahitya. We know that you must have worked so hard preparing all those questionnaires and so simple and with a lot of take-home messages.
Yeah. That was a thing when we discussed with Madam. We kept only one talk. We wanted the panel to be very, very comprehensive and detailed one, and that actually is really appreciated.
Truly, Komal, thank you for having me, and it was really a wonderful session. Thank you, Sujitra ma'am, also to be.
Thank you.
Be with us.
Thank you, Komal. Beautifully organized.
We have some more interesting things going on.
Yes.
Okay. Good night, everybody.
Bye. Good night.
Good night. Good night.
Thank you, Dr. Poonam.